Patients with adult congenital heart disease, some of them are complex, need to be seen by a specialist in adult congenital heart disease. The Houston Methodist system, they collaborate with us on so many areas, and particularly for areas of adult congenital heart disease, the primary care physicians, as well as the adult cardiologist.
Hello, my name is Alan Lumsden, Chair of the Department of CV Surgery at Houston Methodist Hospital.
I'm Joel Garami, the Medical Director of the Vascular ultrasound at Houston Methodist. Although we prefer to meet in person, we recognize how important it is for all of us to continue our medical education. Thus, we are pleased to offer this conference virtually so that you can get the latest updates in vascular ultrasound from the comfort and safety of your own home.
The concepts of vascular ultrasound have not changed significantly over the past few months. Therefore, we're making the video lectures for CME and CNE credit. We hope you'll take advantage of this opportunity. Now, looking forward, we hope to see you next year here in Houston, Texas. Until we meet again, take care and stay safe.
Hello, I'm Dr. William Zogby, Chair of the Department of Cardiology here at Houston Methodist DeBakey Heart and Vascular Center. I invite you to join us for our 11th annual multimodality cardiovascular imaging for the clinician. As you know, cardiovascular imaging plays a vital role in the management of the cardiovascular patient. Knowledge of various imaging modalities is critical to understanding their advantages, limitations, and appropriate use in patients with coronary disease, heart failure, and valvular heart disease. We will highlight the latest advances and applications of all imaging modalities, including echocardiography, nuclear and PET, CT, and cardiac MRI. In addition to didactic lectures by world experts, this conference offers the opportunity to participate in small group tutorials in each imaging modality. Demonstrations of heart anatomy also will help relate imaging to cardiac and valvular conditions. This 2.5-day symposium offers small group read with the experts sessions and allows you to learn interactively using case studies in each imaging modality. Also earn CME credits in this course designed for physicians, mid-levels, nurses, and trainees specializing in cardiovascular care. We also encourage sonographers and imaging technologists in areas such as echocardiography, nuclear cardiology and PET, cardiac CT and MRI to attend. Learn more about this year's exciting agenda by visiting our website. We look forward to seeing you in December.
Good morning. I'm absolutely thrilled to welcome all of you to our 7th annual Adult Congenital Heart Symposium here at Houston Methodist. My name is Huie Lin, and with my partner, Dr. Valeria Duarte, we run the Adult Congenital Heart program here at Houston Methodist. For those of you who have been with us for all of the events in the past, as well as for those of you who are just joining us for the first time today, welcome. I'm thrilled to announce that this is going to be one of the biggest events we've had ever in the last several years. We have now nearly 400 registrants for the event as of approximately a week and a half ago. So welcome to all of those of you who have registered and those of you who have just joined us for the first time. Some of you may actually know that this started out several years ago as just a small event that was between a few friends who are practitioners in adult congenital heart disease. We got together and we started talking about, well, gee, how do we manage these very complicated patients? And do you have any experience with this? Can you tell us a little bit more about how you do this? And we decided that at that point, we should start to bring in other people into this and use this as an opportunity to teach our friends and our colleagues in cardiology, as well as some of our patients and family members who can benefit from what we're learning from each other. And so the Houston Methodist Adult Congenital Heart Symposium was born. Last year, we added another component when we started realizing that there are a lot of adult congenital heart patients within the Houston Methodist community itself. What do I mean by that? What I mean is that when you think about 1% of all live births being affected by congenital heart disease, that means within the thousands of employees within the Houston Methodist community that we have a number of adult congenital heart patients that may not be getting care. And so we started the Adult Congenital Heart Awareness Week the week prior to the Adult Congenital Heart Symposium as a celebration across the entire Houston Methodist community. And so during this week, we've been very busy going throughout the entire Houston Methodist system at all of our system hospitals, talking to people on the ground about the importance of getting good care in adult congenital heart disease. And for those of you who are interested in learning more about this Awareness Week and the Awareness Week events, we have a QR code that leads you to the event. And you can join us for many of the really great educational programs that we did in combination with our patients who are also serving as educators. That's also the theme today, where we're bringing in many of our friends who are experts in adult congenital heart disease, but we're also bringing in our patients because we realize that our patients sometimes have many more years, if not decades more experience of caring for an adult with congenital heart disease, and we love to bring their expertise to the equation. So there are some things as we're going through today that I want to leave you with before we get started. And that is that everyone knows someone. Not only is it important for all of us to learn about taking care of adults with congenital heart disease, it's important to reach out to the people around you, your coworkers, your colleagues, your friends, and your loved ones, because it turns out there's a good chance that they also have somebody in their lives that's affected by congenital heart disease and can benefit from specialized care. The second thing, and you're going to be hearing a lot about this throughout the day today, is that repaired is not cured. We would love to be able to tell our patients that that surgery was the last surgery that they will ever need, that that cath procedure was the last cath procedure that they will ever need. But unfortunately, that's just not true. And so at the end of the day, one of the most important messages that we want to communicate today is that we need you to come in for your care, whether it's through us or our friends at Texas Children's or our friends at Ochsner, et cetera, et cetera. It is so important that you come and get your care on a regular basis. Second to last, it's so important that we know that preventive care can save a life. What do I mean by that? At the end of the day, if we bring our patients into care, if we bring our loved ones who have congenital heart disease into care, we can affect their lives and save their lives. And so it's so important that everyone here today serves as an ambassador going forward to get the message out to their community and their friends and loved ones about the importance of specialized care in congenital heart disease, not only as a child, but as an adult. And then finally, why is this so hard? This is so hard because we have had so much success in the care of children with congenital heart disease that we on the adult side have not been fully prepared for caring for these patients. And so we are now working as quickly and as hard as possible to make up for the time lost. And that is why we have these types of events to get the message out to all of our adult healthcare providers to make sure that we are prepared for the adult congenital heart patients that's going to show up to our practice. So in summary, as we get things kicked off, Everyone knows someone who has congenital heart disease. You might be surprised at how many adults around you know. In fact, there are more adults with congenital heart disease today than there are kids with congenital heart disease. Repair is not cured, and often there continue to be complications post-repair. Early preventive care can save a life, and it starts today. With the information that you're going to get from here today, take that message with you and spread it around the community that's around you. And finally, we need you. Open the dialogue to the people around you and ensure that your friends, your patients get early care to save their lives if they are affected by congenital heart disease. So we're thrilled to have you today. This is totally an interactive session. We want your comments and your questions, not only today, but going forward. Each of us is heavily active on social media. You can see my Twitter handle there. Dr. Duarte also has a Twitter handle. We'd love to continue to field your questions, even if you don't get them in today, even if you're watching this on YouTube next week, 6 months from now, a year from now. We want to get your questions and we want to get your comments, because we can not only answer your questions, but also learn from your experience and expertise. Thanks for joining us today. I can't wait to hear from all of you that are out there, and we look forward to interacting with you not only today, but in the future as well. So without further ado, let's get our program kicked off. We have here in the studio my wonderful colleagues, Dr. Michael Perks from Obstetrics and Gynecology, as well as my wonderful partner, Dr. Valeria Duarte, an expert in not only congenital heart disease, but also the care for cardiovascular patients who are contemplating pregnancy and going through pregnancy. As always, the way to interact with us and get involved in the conversation is to go to pollev.com, that's POLLEV.com, and enter into DeBakey, DEBAKEY. And from there, you'll have a dialog box where you can send in your comments or your questions. I found out the hard way. You have to send in a short comment or a short question because it does get cut off by the system. So if you have multiple comments or multiple long comment or question, please keep it short and then send in multiple comments or questions. If you're using your phone, you can join by text by texting DEBAKEY to 37607 and text in your message, your comment, or your question. Dr. Duarte, we're absolutely thrilled to start this first session, because this is going to be absolutely an exciting session. Tell us what we're going to be talking about.
Hello, good morning. Welcome to our ACHD
Good.
think it was when Huie. Good morning. Thank you for joining us today. Welcome to the 2021 edition of our ACHD Adult Congenital Heart Disease Symposium. We have had a very exciting week, the ACHD Awareness Week, where we have been working with special editions and expert discussions, as well as visits to other hospitals in the Houston area to create awareness about the importance of multidisciplinary care for ACHD. I'm very excited to present the first session in the morning on pregnancy and women's health in patients with congenital heart disease. I have a stellar group of panelists that I'm going to introduce. The first one to my right is Dr. Gary Monteiro. He's one of our cardiac anesthesiologists that supports us through many of the life events of our patients, including labor, delivery, C-sections, cardiac surgery, and non-cardiac surgery as well, doing everything he can to make these procedures as safe as possible for these higher risk patients. To my left, I'm honored to present my colleague from the OBGYN department, Dr. Michael Pirex, who takes care of our high-risk women with cardiovascular disease as they go through pregnancy. He also helps us counseling them before pregnancy on the risks of pregnancy, and we have partnered caring for our patients and supporting them through their pregnancy journey. Welcome, Dr. Pirex.
Thank you.
Joining us via Zoom, we have Dr. Thomas Young, who is an ACHD cardiologist in Ochsner. Welcome, Dr. Young. Thank you for joining us. And also from New York, we have Dr. Simran Singh from Cornell, who is an ACHD cardiologist in the Northeast. Welcome, Dr. Singh. Thank you for joining us this morning. And last but not least, our star ACHD nurse coordinator here at Houston Methodist, Ashley Rift, who will share how we coordinate the care of these patients. Welcome, Ashley. All right, so without further ado, we're going to kick off this session by presenting a case. By no means, the case just means to illustrate the complexity that these patients can present to us. We won't be discussing all the particulars of this case. We will be focusing rather in general questions as we approach the care for these patients. So the patient that we will share today is a 31-year-old young woman with congenital aortic stenosis with a hypoplastic LVOT and also severe valvular aortic stenosis. She underwent balloon valvuloplasty during childhood, and then she was lost to follow-up since she was a teenager. She presented to the emergency room at 19 weeks gestation. On presentation, she had shortness of breath, New York Heart Association class 3, and an echocardiogram demonstrated very, very elevated aortic gradients, the peak gradient of 126 and a mean gradient of 73, with a peak velocity of 5.6 meters per second. So this is a very severe aortic stenosis. It was hard to quantify her aortic regurgitation initially due to flow turbulence through the LVOT, the aortic valve. She's one of the examples where we performed a cardiac MRI during pregnancy to have a better sense of her congenital condition, as she was a new patient to us presenting during pregnancy. which quantify with MRI would quantify her aortic regurgitation as moderate. So a very, very complex symptomatic patient in the second trimester of pregnancy who needed help from a large team to succeed through pregnancy. So I'm going to start by asking Dr. Singh what is if he could share with us what's the approach that his institution has to care for patients with ACHD who are pregnant or wish to become pregnant, because they often will ask us in clinic prior to pregnancy. That's the ideal situation. And if you could tell us about the team at your institution that cares for these patients.
Yeah, absolutely. Thank you, Dr. Duarte. I'd be very excited. It's great to be back at this really important symposium. And I'm very excited to be part of this panel with all the wonderful clinicians and patients who are here today to teach us more about congenital heart disease and pregnancy specifically. So there's a really interesting case, Dr. Duarte, that you brought up, and it's a difficult situation, obviously, when patients come in who are acutely sick and pregnant. That's a situation where we often want to try to avoid, because when we're dealing with pregnant patients, we are thinking on a context of several different things. The context is, one, you really want to do as much as you can in preparation for your adult congenital heart disease patients or any patients with heart disease that's known, to plan beforehand to help set the stage so that the presentations of someone who's 19 weeks and shortness of breath doesn't happen. Nonetheless, in the real world, those presentations do happen. If you don't mind, Dr. Duarte, what I'd like to do is start by just setting the stage about why we worry about pregnancy specifically. And I'm going to share a slide with you. When you think about the normal physiology with pregnancy, there is an increased stress on the body when pregnancy happens, even in the normal conditions. What you end up getting, especially, and it peaks around the mid to late second trimester, you get an increase in blood volume, a decrease in your blood pressure, an increase in heart rate, and an increase in overall the stroke volume, which is the amount of blood that your heart actually expels out to the body, and thus you get more output to the body. But what that can do is cause stresses on a heart that has heart disease or has had prior heart surgery. You couple those basic physiologic principles of pregnancy along with the challenges of delivery. Vaginal delivery can itself cause a sudden auto transfusion of blood, where you get all that placental blood rushing back in quickly after delivery is done, followed by an abrupt blood loss from the delivery itself. There's also increases in blood pressure and output during contractions, which you have to account for. Then C-section has its own set of things where you get a large amount of blood loss, actually more than in a standard vaginal delivery. And of course, the hemodynamics depend a lot upon the anesthetics that are used. So some of the challenges we find in pregnancy are one, that the symptoms and signs of normal pregnancy can mimic those of cardiac disease. It's very common for women to describe lower extremity edema or increasing shortness of breath as they progress in pregnancy, even in the absence of heart disease. But certainly, yes, pregnancy can exacerbate pre-existing cardiac conditions, such as the case you just showed us. Another challenge is that there's patients in whom pregnancy is their first foray since pediatrics into medical care. So this may be their first time that cardiac conditions present. They may not have been aware of a cardiac diagnosis until they get their prenatal care. And there's an ethics involved with pregnancy as a doctor, which is very challenging, because any medication you prescribe, anything you recommend, in turn, you're making decisions for mother, which is the primary focus. And I always say healthy mom equals healthy baby, but you do have the concept of the fetus in mind when you're making decisions. And at the same time, you want to always respect autonomy. I call it manifest destiny of pregnancy, because pregnancy is such an innate part of human existence. It's everyone's right and everyone's business. So we have to be able to care for these patients. So I started off this little speech by saying that preconception counseling is really, really important in these patients. And what you want to avoid is extremes when you're meeting these patients in cardiac clinic. If somebody comes to you and says, I want to get pregnant, you want to look at them holistically. What I find and what we want to avoid is, it's all good, don't worry, just do it, everything will be fine. Versus the other extreme, oh my God, what are you doing? You absolutely can't do this. When obviously in most cases with cardiac disease, the truth is somewhere in the middle. So when you meet patients for preconception counseling, you want to be clear about what you know and what you don't know. You want to talk about the risks and benefits, how we can mitigate those risks, discuss the data and your clinical experience. You want to have a plan and introduce everyone to the team that's going to help with the plan. And you, in any meeting in congenital heart disease, you always want to discuss contraception, always, and alternative options. When is pregnancy not recommended? When is adoption or surrogacy or none of the above the right thing to recommend or consider? But again, respect individual autonomy. As far as the evaluations we do during pre-pregnancy, well, you want to take a really good history and physical, have a great physical exam and check someone's oxygen saturation. And then you do want to do an EKG and echo in someone with established heart disease. I really like exercise stress testing, because stress testing is in some ways mimics the physiologic stress of pregnancy. It's not a perfect surrogate, but it can tell you a lot of information. And if someone does have known aortopathy or aortic pathology, then you should really scan their aorta before they get pregnant. Certainly, there are a lot of risk scores and things that we look at when we're trying to define someone's risk. And I think the WHO classification is particularly useful. But when someone finally does get pregnant, these are sort of, there was a study that came out in 2018 called CARE-PREG-2 that looked at what are some of the highest risk factors for adverse events. And these that are listed from patient history to physical exam, they're the things that we put the biggest attention to, and both in preconception and during pregnancy when we're watching. But remember, while anatomy matters, you can have Fontans who have wonderful pregnancies and patients with ASDs who have challenging pregnancies, because it's the physiology and functional status that matters the most. The final point I'll make is that this is just like in all of congenital heart disease, the pregnancy care in these patients is a team approach. It really does take a village, and you need a little help from your friends. And so what are those friends? Well, you should certainly reach to the guidelines if you're caring for these patients. There's guidelines in the US from ACC and AHA, and I especially do like the European guidelines from 2018 for the management of cardiovascular diseases during pregnancy. And then you need to have a team. Every hospital system will have a team that'll include cardiology and CHF and pulmonary hypertension specialists, of course, adult congenital heart disease and aortopathy specialists, a women's health program that helps with preeclampsia and generalized cardiac care. You need a fantastic MFM and obstetrics program. You need wonderful nursing that's comfortable caring for pregnant patients. And then you need a OB cardiac anesthesia team that also is comfortable during delivery. And with that, let me stop sharing and yield the floor back to you.
Dr. Simran, for that comprehensive review. Absolutely, the importance of the multidisciplinary team here is key and critical, and it takes a village to support these patients, and I thank you for showing your village to us. I think all of our institutions have, through the years, gotten these groups of people together that are very committed to supporting these women through pregnancy. And I think what you highlighted about pre-pregnancy counseling, it's super important. As cardiologists, we're not used to discussing contraception during our visits, but we should. With every woman who is in a childbearing age, this should be discussed. So this can be an educated decision, an informed decision, and also if there are interventions that need to take place prior to pregnancy, then those should be discussed and addressed as well. So I'm going to pass it on to the Dr. Monteiro here, who's joining me today.
Awesome. So my next question is actually for Dr. Young, and can you discuss some patients who do you consider high risk for pregnancy, and then on the opposite of that, which patients do you see that you consider are going to do well through their pregnancy, in contrast to the ones that are high risk? And then finally, a third topic that we already started to touch on, being discussing contraception in your cardiology outpatient clinic visits and how you go about preconception planning with your patients.
Sure. I think the first part of that question can get complicated, specifically who's high risk, who do I think is going to do fine. But before I get into that, I do want to once again kind of repeat what Dr. Singh says. We're not just talking about the mother. And when we talk about risk here, we often focus appropriately on maternal risk, but there's a baby at play here too. And we know that a lot of our patients, their offspring are at higher risk of being born early. They're at higher risk of being born small for gestational age. They are at higher risk as well for being born with congenital heart disease. And making sure we assess that, making sure we refer these patients for fetal echocardiograms, typically about halfway through the pregnancy, so we can make sure the baby is doing okay as well, is really, really important. Once we get to the discussion about the mother and the risk, I think what is really important is to understand that, number one, all of these kind of risk assessment systems, the scoring systems we have, are very imperfect. And each patient is different. And we who take care of adult congenital heart disease patients know that every single ventricle Fontan you take care of is different. Every tetralogy patient you take care of is different. And these are individualized discussions that we have with a patient or a couple, and not with a large group of people, because everyone's different here. But we do have some help with this process of assessing risk and giving guidance to our patients. And as mentioned already, there are a lot of guidelines and scientific statements out there. The 2017 HA, American Heart Association guidelines on management of pregnancy in patients with congenital heart disease, exceptionally helpful, as are the more recent European guidelines, and really kind of dive into not just each individual lesion, but the physiology of pregnancy and how it affects these patients. And when you look at kind of guidance for this, I think the most helpful, and I'm going to try to share a screen here to see if this works. Let's see, am I sharing?
Yes. Yes, we can.
Yeah, but I think I'm sharing the wrong one. Are you seeing this join live? Oh, wait, you do? Okay, hold on, let me do this.
You just need to hit present. Yeah, perfect.
Okay, is that good?
Perfect.
The miracle. So, if we look at the World Health Organization pregnancy risk categories, I think these can be really helpful when we discuss pregnancy risk with our patients. And as is typical, I think it's exceptionally helpful when you look at the extremes on here. So who do we think is going to do well? Well, clearly that's the category 1 patients. So these are patients who had mild pulmonary stenosis, patients with a small PDA or mild mitral valve prolapse, patients with successfully repaired simple lesions like ASDs and BSDs. These patients we expect to do exceptionally well with no real increase in maternal mortality, maybe a mildly increased risk of adverse events like arrhythmia or swelling, but we expect these patients to do exceptionally well. The opposite end of that spectrum are the category 4 patients. And these are the patients that really should be counseled against pregnancy. And I think we have evolved as physicians from being exceptionally paternalistic. And I'm old enough to remember the studies, looking at, okay, what were the pregnancy outcomes in tetralogy patients? What were the pregnancy outcomes in coarcts? And it feels like all of those studies kind of started, 100 women were told never to get pregnant, and 75 of them got pregnant. And I've joked that I should start a fertility clinic because patients I counsel against pregnancy have a fairly high rate of getting pregnant. But if you look at these category 4 patients, these are the ones that really do poorly. And they include patients with pulmonary hypertension, and that's going to encompass our Eisenmenger's patients as well. Patients with severe systemic ventricular dysfunction, typically a left ventricular ejection fraction less than 30%, or severe systemic right ventricular function. And these are our symptomatic patients, New York class 3 and 4. Patients with a previous history of pericardial cardiomyopathy who still have some residual LV dysfunction, severe mitral stenosis, significantly enlarged aortas, both in our Marfan syndrome patients and our other kind of genetic aortopathy patients, along with our bicuspid aortic valve patients with aortic aortas greater than 5 centimeters there. And our severe coarctations, whether those are native coarcts or repaired coarctations with recurrent obstruction. And then importantly for our patient here, severe symptomatic aortic stenosis. So the patient in our discussion clearly should have been counseled against pregnancy and should have had intervention prior to getting pregnant. But this category 4, these are the people that we need to, from an early age, start saying you shouldn't get pregnant. And if there's something we can correct to get you out of that category 4, we need to do it. And these are the patients where during pregnancy, you have to have those difficult discussions about, is pregnancy termination the appropriate course here? There are some more recent kind of guidelines based on this. There's a great article about a year ago in Heart looking at risk prediction and counseling in our congenital heart disease patients and giving some recommendations not only about risk, but also about where they should be delivered and how often we should follow them up. And once again, that modified WHO class 1 patients, and then the class 2 patients as well, such as repaired ASDs or BSDs and repaired tetralogies who look great, very specifically the repaired tetralogies who have good biventricular function and no arrhythmias and those kinds of things. Those 1s and 2s can be seen a few times during the pregnancy by their cardiologist, but you could expect them to deliver at a local hospital. They don't need to come to the Mecca to deliver, which is really important because a lot of our patients come from hours and hours away to see us, and it's quite difficult to get somewhere 4 hours away for a delivery. Contrast that to the 2-3s and the grade 3s there, and these are patients that are considered at higher risk for maternal mortality, and certainly at significantly higher risk for morbidities, for complications during the pregnancy. There are a number that can be mentioned there, but a few I really want to mention are the mechanical valve patients. Those patients on Coumadin for their mechanical valves are considered high risk and need to be followed very closely. Our Fontan patients who are doing well, so these are kind of those perfect Fontans that you see that don't have heart failure, don't have a risk of stroke or other thromboembolic events, don't have protein-losing neuropathies. They're still class 3s. We need to follow them very closely, and they need to be cared for by the big team there. And these are patients that you're going to be seeing, once a month, maybe once every other month, and they're going to come to your center to deliver where the entire team is present to help with this. And so kind of those 2, 3s and 3s I would consider high risk. The 4s are exceptionally high risk, and pregnancy should not be recommended. If you look in these recommendations, they've placed symptomatic Fontans in the 4. And I agree with that. My Fontan patients who have protein-losing neuropathy or who have other significant complications from their Fontan circulation, I advise against pregnancy. But I've found this to be really helpful when I talk to these patients. I'm going to stop my sharing, and I'm going to real briefly talk about the nice little softball you threw up for me about should we discuss contraception, which is a pretty easy one. Obviously, the answer is yes. And I would throw on that we should discuss it early. So this is not a discussion that should start in a 22-year-old. This is a discussion that needs to start with teenagers and really early teen years. And I typically start this, in the 13, 14-year-old range with my patients when I see them in pediatrics. And we discuss and often it's worded as something very positive. You look great. I expect you to be able to someday carry a pregnancy successfully if that's what you want. And then we talk about birth control. Not a discussion to start once the patient is certainly already sexually active. And specifically, we want to get into the specifics of contraception. And I preface that by saying I am not an obstetrician. I don't pretend to be one or play one on TV. And so I often leave those discussions to a large extent up to the patient and their obstetrician. But we know that estrogen-containing birth control pills increase your clot risk. And a lot of our patients are already at increased risk of clotting. And we want to avoid those estrogen-containing pills. We know that the progesterone-only pills are often not as effective. And we have certain patients that we really don't want getting pregnant. And so those patients, often a discussion about tubal ligation or other more permanent forms of birth control are appropriate. Although with those class 4 patients we discussed, the anesthesia associated with the tubal ligation could be pretty risky. So we really individualize these discussions. I push the newer IUDs quite a bit. They're effective, they're safe. There is a certain stigma still against IUDs that I remember from early in my training, but the newer ones are very safe and very effective. One thing I definitely want to mention that I've seen before is I've seen patients come to me and their pediatric cardiologist at some point said to them, whatever you do, you can't get pregnant. And what the patient heard was, whatever I do, I can't get pregnant, And the reality is, the vast majority of our patients can get pregnant. Just because they have severe heart disease doesn't mean they can't get pregnant. We need to assume our patients are able to get pregnant, and we need to have those discussions and counsel appropriately. And I'll turn it back over to you guys.
Thank you so much, Dr. Young, for that comprehensive review. I have here Dr. Pirex by my side, so I'm going to quickly ask him to comment on his approach to our patients. We often start the conversation about contraception. It's hard to make a decision with all the options. We know from a cardiac perspective, like you mentioned, which ones are safer, but nobody's better than our OB specialists to discuss with them the benefits, the risk, the pros and cons, and the characteristics of each of them. So we often initiate that conversation, and before I forget, I want to mention that if your cardiologist doesn't initiate that conversation as a patient, I'm just talking to the patients now, then that should be asked. That question should be asked and should be addressed in the cardiology clinic, and we often complement that with a visit with the OB specialist who can expand on the contraception options and make the recommendations. So I'm going to ask Dr. Pirex to comment on that, and also to tell us what support does he need from the cardiology team as he cares for these patients during pregnancy. And also I would like to ask him what's the importance for him of having a trained cardiovascular anesthesiologist who understands congenital heart disease to support him not only through labor and C-section but also through other GYN surgeries.
Well, of course. Thank you for asking me to be here. It's been an honor to help with this program and our patients that we share together here at Houston Methodist. I really liked your comment, Dr. Young, about just because you don't think you shouldn't get pregnant. What's that? Is that steel magnolias? Just because your doctor said you couldn't get pregnant, no, you shouldn't get pregnant. They're not the same thing. And I feel like the education on that is something that I deal with frequently in any of my patients, is talking to them about their own risks of being pregnant. And so when we take it into adult congenital heart system, it's even more important that we talk about that safe and effective contraception. And so a lot of the IUDs that Dr. Young mentioned, that is a very common option for these patients who want to preserve their fertility if they would like to try to achieve a pregnancy later, or even if they really not planning on getting pregnant, but they want to avoid those anesthesia risks with the tubal, because an IUD typically has the same failure rate as the tubal ligation, and so, which sounds crazy, but they actually they're almost exactly as effective. So they're very good birth control methods for any patient, but especially patients who need to avoid pregnancy for those reasons. In terms of what I like to have as an OB-GYN provider is it's really nice when patients come to me and they know a lot about it, and you guys do a lot with education on these patients, and it's really wonderful when they said, well, Dr. Duarte has told me that, and they go through this list of things. I'm like, oh, okay, well, you have made my job a lot easier today, thank you, so thank you. But also, it gives me kind of a framework to start with. I know I can have an expectation of what the patient already knows or doesn't know. Sometimes it's as simple as, if I have a question, I can easily say, I'm going to step out, I'm actually going to call Dr. Duarte, and I've done that before too. So I think it's very nice to know that I have the support of my adult congenital heart specialist when I take care of these patients, and I've told many of my residents that I probably wouldn't be doing what I'm doing if I didn't have this kind of community around me of support, because I wouldn't take on a lot of these patients, these risky patients in a community hospital. In terms of the pregnancy itself, the preconception counseling is absolutely, it's definitely the mantra for today. Preconception counseling is important for everyone, whether they're adult congenital heart patients or anyone else, because we can talk about expectations, we can talk about how to prepare for pregnancy, how to avoid certain problems in the very beginning. During the pregnancy, it's nice to know kind of what we might expect. So what are we going to expect when those physiologic changes that Dr. Singh mentioned, what is going to happen to this patient's heart? Because I am a gynecologist and I am not a cardiologist, and nor do I play one on TV. And so I don't remember a lot of those things, and I have to educate myself. And so it's very helpful to say, okay, when they get into the third trimester, we might expect this sort of problem, be looking out, because I'll see this patient a lot more often, especially towards the end of pregnancy, because I'll be seeing them every 2 weeks or every 1 week towards the end. So I'm very happy to be looking out for some of these problems as well. And then I like to also make sure I know kind of what the expectations are for delivery. We've had patients we can deliver in a normal labor and delivery room. We've had patients we've had to deliver in ICU rooms or in an OR, to do a C-section in it's kind of unusual settings, away from our L&D. And so it's nice to kind of have that in mind, that this patient is likely to need this level of support during delivery. I also like to know that because I like to prepare my patients for that, because pregnancy is obviously, and the delivery is a very it's a very momentous time in someone's life, a family's life. And so it's very important to most patients that go as well as possible, and that's just kind of the experience that goes along with it. So if we can create as normal of an experience as possible for the delivery, that makes a huge difference for these patients. And so I think that's really important. We've had really good successes where normally fathers have not been allowed, and we've kind of put them in this corner of the ICU, and so that we can kind of slip him in and out a back door. I remember that was right when COVID started too, so it was like a double whammy on that one. So that one, I know that alone probably made that birth experience just really amazing for those patients, despite being in an ICU. So it's been really kind of it's a challenge sometimes, and it doesn't always work, but I think that's really important. We also we have had the experience of, as we get closer to the planned delivery, we try to meet with the nursing staff and the ICU directors and things like that to talk about the logistics of what would happen. I've often said luck favors the prepared, and the obstetrics is obviously one of the least predictable fields in medicine, just because in addition to all these other problems they may have with their own health, the pregnancy itself there's no way to predict what's going to happen. I know several obstetricians who have crystal balls on their desks and use that as a point. Well, I don't know what's going to happen. Look in this crystal ball. And so making as much of a plan as possible so that when the unexpected does happen, you're as ready for it as possible makes a huge difference for the staff as well. And then the last question about anesthesia, I don't know what I would do without Dr. Monteiro and his team of CV anesthesiologists. They make it seem easy, and I know it's not. I know very well it's not. But it's really nice to be able to say to a patient, look, your CV anesthesiologist has a particular interest in not only adult congenital heart disease, but also has helped us on many pregnancies in the past. They're very aware of these patients. A lot of these patients have a fear of the OR because they had so many surgeries as children, and so I think they're very welcoming. They're very supportive of our patients. And then in terms of the technical stuff, I know that as a surgeon, sometimes we don't like to say it, but it's not my show. It's anesthesia's show, and it's really nice to know that we have someone running the case who's an expert in what they're doing. And so I can do a C-section anywhere. I'd rather do it in the care of Dr. Monteiro, that's for sure.
Thank you, Dr. Pirex. That was a very comprehensive review, and I think it gives our patients a very good grasp of how we approach this from an OB and MFM perspective. Before we move on to the next question, I would like to remind the audience that they can send us their questions by text. If you text DeBakey, and you will see the instructions on the screen, text DeBakey to 37607 and then text in your question. Or you can also connect with us via the web. If you go to paulev.com and enter DeBakey and then just respond to activity and send us your question, our panelists will stick around for a few minutes to answer any questions you may have. So moving on, I would like to hear from Dr. Monteiro, our CV anesthesiologist. Dr. Monteiro supports our patients through all their journeys. He supports them through their cardiac surgery, the heart and multi-organ transplantation, and he supports them through their non-cardiac surgeries, the GYN surgeries, and also the endocrinology surgeries, the thyroid surgeries, the orthopedic surgeries. Our patients have needs as they go through life, and we can always count on him. He has training on top of his cardiovascular and anesthesia expertise. He has training to treat patients with congenital heart disease specifically and patients with complex congenital heart disease. So we definitely rely on him at the time of labor and scheduled C-sections, and he's a big part of this team. And like Dr. Pirks mentioned, why we're able to accomplish this and get through these challenges with our patients. It's because we have expertise. So, Dr. Monteiro, can you please elaborate and tell us, from a cardiac anesthesia perspective, we all know, like Dr. Singh clearly outlined, that labor and surgeries in general are associated with hemodynamic changes, and anesthesia is associated with the hemodynamic changes as well. So how do we make labor, C-section, and other surgeries safer for these patients in your OR?
Well, okay. I hope I can live up to all that expectations you guys have put on me. One of the key things when you're dealing with patients with congenital heart disease from the spectrum of simple to complex is, and it's been mentioned already today multiple times, is individualized care. Every single one of these patients is different. Patients aren't defined by their lesion. They're defined, I liked how Dr. Singh said he looks at they're more defined by their physiology than their lesion. Many of these patients, it's super helpful to meet them before surgery, before labor. Sometimes I'll wander over to the cardiology clinic if there's a particular patient that we're interested in or will be coming in for a non-cardiac surgery. And I like to discuss expectations. I'm going to focus on labor and delivery. I like to discuss the expectations, and like Dr. Pirks said, I want to make this experience as normal as possible. We joked about sneaking dads in. You know, it's very common for or not just dads, but for partners to be present during delivery for C-sections, you know, and we'll make our little corner on the anesthesia side so that people can be there, maybe sneaking them in a little bit. But I describe the expectations. I say, in the patient that we presented this morning, you know, it's going to be a little bit different for you. You might get a central line. This patient, you know, you may have invasive monitoring. You may have an A line. You know, there are different ways to do this. You know, you may have be delivering in the ICU. We may be monitoring you continuously, whereas in a normal patient we wouldn't. We may have you labor in a cardiac operating room with ECMO on standby and a cardiac surgeon. You know, it's very individual to the patient. One of the things that I say that makes these patients have a safer anesthetic experience, particularly in OB, is preoperative planning, having a backup plan for your backup plan. Monitoring people with a little more attention to detail than perhaps the standard patient. Patients with this patient in particular, we discussed putting in an A line. We discussed different forms of anesthesia for her, from neuraxial anesthesia, which includes, of course, epidural and spinal. Two things where, if you're in the anesthesia world, people talk about avoiding in patients with severe aortic stenosis, but we've been, you know, very successful with labor and C-sections under neuraxial anesthesia here. Where do you want to perform the surgery? Where do you want to perform labor is also a discussion that we like to have, because the cardiac OR is very different setting than delivering in the cardiac surgery ICU. Our OBs and our cardiologists are going to discuss with the patient the delivery plan, whether it's C-section or labor, and those require different anesthetic, different anesthetic planning, even though, you know, we can always switch back and forth. And then one of the things I always think about is, when do I like to have a cardiac surgeon available? When does the patient so decompensated that we're having the ECMO conversation, which isn't that often, but, you know, we do have it. Dr. Singh talked about the changes in pregnancy, decreased SVR, increased volume, increased stroke volume. The other thing that we need to talk about is pain associated with labor. How do we provide labor analgesia, and how do we do that individualized to not just the cardiac lesion, but the patient's physiology? It's not just it's not just epidurals in the standard way that we would do an epidural for any pregnant patient that came in. We have the ability to alter our medications that are in the epidural infusion. We can alter the rate, what's in there. So there's lots of tweaking we can do. There's also other ways of making people comfortable in labor other than just epidurals. So these are all discussions we like to have beforehand. But like I said, and everyone's going to emphasize today, individualized care for every single patient, especially pregnant patients. Pre-planning, not just counseling, but the whole team having an individualized sense of care. And like Dr. Perrick said, there's no crystal ball. We've had so many patients who you set up a plan and then they go into labor, 2 days before their scheduled C-section in the cardiac operating room. Or they decide to deliver in their ICU bed 15 minutes before we head down to the operating room for a C-section. OB requires, OB anesthesia on the cardiac side, or just anesthesia in general, I think requires for sick patients a little bit of professional flexibility to, and you want to be able to have your team providing care in all different settings. It's like, the famous boxing saying, everybody has a plan until they get punched in the face. And I always feel like that when the plan changes. The best laid plans, you're always on plan B or C. So when something goes according to plan, everyone's super happy. But again, let me emphasize for the final time, individualized care and planning and team dynamics and communication. So with that, I guess I'm going to move on, and I have a question for Ashley, who's our ACHD nurse coordinator. Talking about planning ahead of time. How do we plan multidisciplinary meetings? How do we get all these people together? Who needs to be involved? Obviously with the advent of Zoom, it's a lot easier, but how do we get all the players together, and how do we get everyone to play nice in the sandbox?
So I think for the most part, everybody talks about really individualized care, and it's really about building a team around the patient. For us, I think the most important thing is really keeping in mind, what does the patient want? So, we have Dr. Perrick there, whoever the obstetrician is, and, a lot of times they're bringing that information that they're getting because they're seeing the patient, and they're kind of discussing kind of what that patient's ideal is as far as birth plan goes. And then Dr. Duarte is bringing from the cardiology side, what has the patient shared with them as far as what they would like to see, what their ideal delivery would be. And then of course we have anesthesia, and then we may have maternal fetal medicine there. We have a ton of nursing there, so we try to have just about any place, any unit that our patients may touch, we try to have a representative of nursing from that unit. So we have a postpartum, we have CVICU, we have obviously women's health. We're going to see, OR if the expectation is that patient might deliver in the OR. I know Dr. Monteiro, you talked about things not always going to plan, but we try to build that birth plan so that there is that plan B, that plan C, and we do provide that birth plan to everybody, that the patient may come in contact with. If the patient needs a pulmonologist, we want to invite them to our pregnancy conference. Whichever internal medicine doctor may be the one admitting the patient, if the patient is admitted prior, we want to have neonatology there if that's going to be a need, respiratory therapy. You mentioned cardiac surgery if we think that a surgeon might be needed. So we try to have a representative from just about everyone that is going to be on that team when the patient's delivering. Sometimes that meeting's long because there are definitely some disagreements in the beginning a lot of times as far as a maternal fetal medicine doctor may see things differently than Dr. Duarte, who may have a plan in mind, but nursing tells us, well, I don't know if that really works with our current level of staffing, or do we have a nursing staff that maybe is newer and doesn't feel as comfortable in a certain setting dealing with a congenital patient, which of course then crosses over into us really being able to identify who needs that education as far as congenital cardiology. So I think it's really just all about trying to support the patient through and really in some ways be almost as invisible as possible and let them kind of have as much of what they envision of their ideal delivery as possible, but also make sure that we're prepared for anything that could come up, any kind of contingency plan is there. I know, we do a great job at kind of, always being able to catch plan B or catch plan C. And we've had some really successful deliveries with our ACHD patients. I think that will just continue as we really have this group, this care team around the patient.
Thank you so much, Ashley, for covering that. I think having a coordinator that like Ashley is critical for these multidisciplinary teams, and keeping a relationship with all the different teams involved, the OB/FM, the anesthesiologists, the cardiac units, the OR, and having good documentation of these discussions as well is important in the patient's chart, so that when the time comes, we have a plan and we have a contingency plan, like Dr. Monteiro highlighted. Sometimes not everything can be planned, but we can, with experience, we can anticipate some potential issues that may arise and have a contingency plan for those. I think we're running out of time. We have gotten some very good questions. There is one that came a few times, so we're gonna focus on that, address that very quickly. The question I'm talking about is regarding termination, in which cases we discuss termination, and that's a hard question to answer. What I'm gonna say is that we do everything we can not to get to that discussion. So everything that Dr. Singh, Dr. Young, Dr. Pierce have highlighted, we are focused to prevent that situation. So the pre-pregnancy counseling, the education, the contraception in patients who have very high risk for pregnancy, educating patients on their likelihood of getting pregnant, that it's a source of confusion, especially in very young patients. So that we try to prevent that. Also keeping patients in care. Like the patient we presented today was lost to follow-up for many years, teenage years, critical years. So keeping those patients in care so they're appropriately counseled is very important too, to prevent that, and doing appropriate transition from pediatric to ACHD care. It's also important, but sometimes we do get there. Also, when we see patients in pre-pregnancy counseling, and there are issues that need to be addressed prior to pregnancy, a valve replacement. So we plan ahead so that pregnancy is safer. But when the patients present like this one to the ER with symptoms and heart failure symptoms and very significant disease, that termination is something that we think about. We try to support our patients to the best of our ability, while at the same time we just need to make sure that we keep them safe. So this is part of the discussion and the thought process of the multidisciplinary team, and that's the importance of having a team of experts. We will always try to keep both mom and baby safe, and So termination is discussed in very extreme, but is pursued in very extreme circumstances where we feel that the mom's life is at risk from a cardiac perspective. And I'm going to have Dr. Pirek's comment on that.
Sure. Well, access to these conversations are obviously very controversial, no matter when you're having them, whether it's preconception or after a pregnancy, or if things are going very poorly, and the discussion for a medical termination has to be had with the patient. But just as I think it's also important to recognize that just as it's important for the patients who want to become pregnant to be able to make that decision, knowing the risks they have, that it's also not my place as an obstetrician to prevent them from altering or terminating a pregnancy in order to mitigate some of those risks for themselves. And so while I'm going to stop before we get too political, but just saying that access to any type of care in this situation is going to be very important.
Thank you, Dr. Pirek. And what we always tell our patients, they're the captain of this boat. We counsel, but all the decisions, the difficult ones and the others, they're all made as a team. The team of experts that counsels and the patient. So with that, I would like to conclude this session. I would want to thank the audience who have joined us very early this morning, and my panelists, Dr. Gary Monteiro, Dr. Michael Pirek, and from their respective states, Dr. Young and Dr. Singh, and Ashley, who's always supporting our team through these endeavors. Thank you very much. We're gonna take a couple of minutes break, and we'll come back with the next session about the challenges of Eisenmenger. Welcome to our second session this morning. We will be discussing a very exciting and complex topic. We will talk about challenges in Eisenmenger syndrome and pulmonary hypertension in adult congenital heart disease. And to discuss this critical topic, I'm going to have the honor to share the screen with a number of stellar panelists joining us from different ends of the country. So first I'm going to introduce here on my right in the studio Dr. Gary Monteiro, who is one of our cardiovascular anesthesiologists who joined us in the prior session too. Dr. Monteiro, welcome again.
Thank you.
And then joining us via Zoom, we have Dr. Peter Hermes, who is the director of the Adult Congenital Heart Disease Program at the Texas Children's here in Houston. We also welcome Dr. Hermes.
Thank you.
We also have Dr. Stephanie Fuller, who will also be accompanying us in our transplant discussion. Dr. Stephanie Fuller is a cardiovascular surgeon with expertise in congenital heart disease, with a long trajectory guiding us to help to care for these patients. Welcome, Dr. Fuller.
Thank you, Valeria.
Dr. Fuller is joining us from Philadelphia. She belongs to the ACHD team, and she's one of the directors at UPenn and in the Children's Hospitals of Philadelphia. Next, I'm going to introduce Dr. Jonathan Gins. Dr. Gins is an ACHD cardiologist at Austin Heart. Thank you for joining us today, Dr. Gins.
Thanks, Valeria. Thanks for having us.
And then last but not least, we have, again this year, he has been supporting us for several years now, Dr. Pankaj Madam. He is the director of the ACHD program at the Methodist in San Antonio. Welcome, Dr. Madam.
Thank you, Valeria. Thanks for having me here again.
Well, now without further ado, let's move on. We're going to kick off the discussion by sharing a real-life case. But by no means we intend to discuss all the details of this complex case. We just would like to present it to illustrate the complexity that comes with the care of these patients and to help us guide the discussion. So the patient that we're going to briefly discuss is a 54-year-old man with Eisenmenger syndrome who presents for initial evaluation for candidacy for heart and lung transplantation, referred by one of our esteemed ACHD colleagues here. He was lost to follow-up, unfortunately, for several years due to insurance issues. And unfortunately, that's a frequent story we hear. His anatomy is very complex. He has unrepaired D-loop transposition of the great arteries with a large unrestricted VSD. With this, he has a single ventricle physiology. I'm going to quickly share some of the images of his heart with the audience. You can see here on the left side of the screen the great arteries and their abnormal relationship. He had also a decreased ventricular function, biventricular function, that we quantified on MRI at 27%. So the ejection fraction was 20%. In addition, the tricuspid valve had at least moderate tricuspid regurgitation, and you can see it here in this image. You can also see the tricuspid regurgitation in the short axis, and you can see that the mitral valve is functioning normal. Again, a very large unrestricted VSD. And just to make things a bit more complicated, he was found to have a very large PDA, patent ductus arteriosus, that was also heavily calcified, that adds to the surgical complexity of this, as we're planning how to approach this patient. He underwent a cardiac catheterization. This is just a brief summary. I just wanted to highlight that the aortic saturation was 69.5% in the cath, and also that the pulmonary pressures were severely elevated, with PA pressures in the 90s, with a mean PA pressure of 65, and a PVR of 19 Wood units. He had a plethora of other clinical issues that we always need to keep in mind, and that are not infrequent in these cyanotic patients. Like, he had thrombocytopenia, erythrocytosis, with a hemoglobin of 22 and a hematocrit of 64, hyponatremia, proteinuria with associated hypoalbuminemia of 2.9. He had documented non-sustained VT. He had abnormal imaging of the liver that prompted a liver biopsy, and he had a diagnosis of cirrhosis, unfortunately, in the liver biopsy. So we encounter a patient, in summary, who has unrepaired, great complexity, congenital heart disease, who has been cyanotic his whole life, and shows signs, clinical signs, and organ signs of chronic cyanosis. So I'll move to Dr. Gins to just remind us and help us refresh and help our audience refresh. What is Eisenmenger syndrome? How do we define it? And what are the causes?
So thank you, Valeria. There we go. So Eisenmenger syndrome is essentially, it's a complication of an uncorrected left to right shunt that has led to increased pulmonary vascular resistance and pulmonary hypertension, with eventual reversal of that shunt. So in this particular man, he had a large VSD that within, at birth, he would have developed left to right shunting, and then within a year or two of life, he would have developed significant damage to the pulmonary vasculature, leading to endothelial dysfunction, thickening of the media and intima, and eventually irreversible increase in his pulmonary vascular resistance. And eventually that would have led to right to left shunting due to the higher pulmonary vascular resistance than the systemic vascular resistance. So you can see someone with a large defect will have left to right shunting initially, and as the pulmonary vascular resistance increases because of the damage to the pulmonary vasculature from the increased flow, we eventually see bidirectional shunting. And then where there's right to left shunting, essentially that's what we will call Eisenmenger syndrome, and this correlates with at the beginning a low pulmonary vascular resistance when there's left to right shunting, and a high pulmonary vascular resistance when there's right to left shunting, so causing cyanosis. And that corresponds with this appearance histopathologically of a thickened media and a thickened intima. And so you can see this is a normal blood vessel, normal pulmonary arteriole here. And this is a pulmonary arteriole on someone affected by Eisenmenger syndrome. So you can imagine very difficult to get the blood flow through those very tightly narrowed vessels. So the patients that are at risk for this are essentially dependent on the size of the left to right shunt, the size of the lesion. So a very small VSD is very unlikely to develop Eisenmenger syndrome, but a larger VSD will develop significant left to right shunting and then subsequent right to left shunting. And particularly susceptible are patients with AV canal defects, with Down syndrome, large PDAs, like your patient has multiple lesions, aortic pulmonary window, and DTGA, like your patient with VSD, and truncus arteriosus, and some of those lesions. It's almost universal to have Eisenmenger syndrome. In an atrial septal defect, it seems to be less common. If it's a very large defect, greater than 2 centimeters, and these patients may present with Eisenmenger syndrome later in life, whereas the large ventricular septal defects will develop Eisenmengers very early. And it's felt that the prevalence of Eisenmengers is around about 10% of adult congenital patients, so it's something that we run into frequently in adult congenital heart disease. And the syndrome itself, often these patients will have a long symptom-free period. So we see a lot of patients who are actually functional and doing really well, but then in their late, sort of early to late adulthood, will start to develop symptoms. So it's not uniform. The average lifespan is around about the 40s, but we certainly see patients up to 50s and 60s. Particularly when they develop symptoms, it'll often present with shortness of breath, fatigue, or syncope. And these patients will develop some heart failure, particularly right-sided, like in your patient, with edema and effusions and liver dysfunction, arrhythmias like atrial fibrillation, flutter, and sudden cardiac death, pulmonary and systemic thromboembolic events, and obviously they're hypoxemic with high red cell counts, and although hyperviscosity tends to be uncommon unless they're dehydrated, so we avoid venous-affecting them. Then other complications outside the cardiovascular system, including gout, hemoptysis, infections, gallstones, HPOA, and impaired liver and renal function. Thank you.
Thank you, Dr. Gins, for that review. It's a complex topic to review briefly, but I think you gave us a very, very comprehensive idea of what this entails and the complexity of that these patients bring with them. I'm gonna now let Dr. Monteiro take the lead.
Awesome. I'm going to ask a couple questions here to Dr. Madan. What is your approach when you're thinking about medical management and clinically optimizing a patient with Eisenmenger's? And then secondly, are there any ACHD guidelines that recommend specific therapies in these patients to optimize them?
Thank you, Gary. I'm going to share a few slides of mine with the audience and everybody.
Perfect. We see them, Pankaj.
Okay, good. So pulmonary vasodilators have emerged as a mainstay of medical management of Eisenmenger syndrome. And there are several classes of pulmonary vasodilator medications. These are endothelin receptor antagonists, and the examples of which are bosentan, ambrisentan, macitentan. Then there are phosphodiesterase 5 inhibitors, of which sildenafil and tadalafil are examples. Then there are prostacyclins, which can be in oral form, such as selexipag, or IV forms, such as treprostinil. So let's review what the ACHD guidelines say about the initiation of pulmonary vasodilator therapy. The top 3 recommendations are from the ACC-AHA guidelines, and the last one is from the European Society of Cardiology guidelines from 2020. So according to the ACC-AHA guidelines, bosentan should be started in symptomatic patients. That's a class 1A recommendation based upon the results of BREATHE-5 study. Then this 2A recommendation is for phosphodiesterase 5 inhibitors in symptomatic patients. If one agent doesn't lead to improvement, then add another sequential therapy. That's a 2A recommendation. The main difference between the European Society of Cardiology guidelines and the American College of Cardiology guidelines is this combination therapy. The European Society of Cardiology guidelines advocate that all risk patients should be started on combination therapy upfront, and this recommendation is based upon the results of Ambition trial that was published in New England Journal of Medicine a few years ago. Our goal with the pulmonary vasodilator therapy is to keep these patients in the low risk profile, and we bring these patients every 3 months and check their biomarkers, NT-proBNP, 6-minute walk test, and echocardiogram, just to make sure that they are trending in the right direction. And if they are not, then further escalation of therapy with other agents such as IV medications may be warranted. And then of course at that time we also have to consider them for a combined heart-lung transplant. Equally important in these patients is treatment of iron deficiency anemia. And these patients often have cyanosis or decreased oxygen saturation, like the patient that you showed us here. Decreased oxygen saturation is a powerful stimulator of increased erythropoiesis or RBC production. Increased RBC production requires good amount of iron stores in the body. And if sufficient iron is not available, it can lead to iron deficiency. Iron deficiency leads to decreased RBC survival time. It reduces RBC oxygen carrying capacity. These RBCs become rigid and cause an increase in blood viscosity. In fact, microcytic anemia from iron deficiency was one of a major predictor of CVA or TIA in this patient population. Therefore, it is important to monitor iron stores periodically and then supplement iron whenever you see iron deficiency anemia. And you should also, in 3-4 weeks, ready to discontinue it when the hematocrit rises and once the iron stores are depleted. And it is, from the medical management standpoint of view, it is also important to avoid routine phlebotomies so that you do not precipitate iron deficiency anemia. Phlebotomies should only be done if the patient has unequivocal signs and symptoms of hyperviscosity syndrome, and even then it should only be done after making sure that the iron stores are still replete. And if you do them, then you should always substitute it with some colloids. In my own practice, I don't recall anybody undergoing phlebotomy for hyperviscosity syndrome in the last 3-4 years. But I have several patients referred to me who have undergone phlebotomies elsewhere just to bring their hematocrit down. It is also important to avoid transvenous devices or wires, because these devices and wires can develop thrombus on them, and through that shunt, the clot can travel and cause cerebrovascular accident. It is important to avoid routine anticoagulation or aspirin use, because Eisenmenger syndrome is a state of both increased thrombotic state and also with increased bleeding. And if we use routine anticoagulation or aspirin, then it can lead to increased bleeding episodes. So the use of anticoagulation or aspirin should be restricted only if there is, some other overwhelming recommendations such as atrial fibrillation or flutter or prior history of TIA. So, Dr. Gins also mentioned choledocholithiasis and cholecystitis as one of the complications of Eisenmenger syndrome, which happens quite a bit. And when these patients need cholecystectomy, it is always important to involve an anesthesiologist doctor like Dr. Monteiro, who is familiar with the physiology of Eisenmenger syndrome, because even routine surgeries can carry a 20 to 30% mortality rate. I think that's about it. Thank you.
Thank you, Dr. Madan, for that comprehensive review. It's definitely very important to optimize this patient clinically as we think about other therapies. I would like to ask Dr. Monteiro, from a cardiovascular anesthesia standpoint, when these patients with Eisenmenger syndrome need non-cardiac surgery, elective and sometimes emergent, why are they considered high risk? And how do we make surgeries as safe as possible for them?
Awesome, thank you. When I was reading the presentation of the patient earlier, I was relieved that they were actually having cardiac surgery and not non-cardiac surgery. Having a patient with complex congenital heart disease, specifically Eisenmenger's, in a cardiac operating room with a cardiac surgeon is a lot more comfortable for me than, say, doing a cholecystectomy or say an orthopedic procedure with a surgeon that's unfamiliar with some of the cardiovascular risks of these patients. Dr. Madonna had mentioned that they're considered, in the anesthesia world, Eisenmenger's is considered extremely high risk, to the point where it may preclude elective surgery in these patients. Cosmetic surgery would be a very risky and elective procedure that you would have to definitely counsel the patient on. Emergent surgery in patients with Eisenmenger syndrome is an interesting topic. These patients are particularly at high risk. One reason is because their oxygen saturation is low due to their shunt. Anesthesia in general can increase the degree of desaturation because most anesthetics, particularly general anesthetics, can decrease the systemic vascular resistance. The other thing we always worry about is paradoxical embolism, because there's the connection between the right and left circulations, of course. We always talk about the goals in these patients is to maintain the blood pressure, maintain the cardiac output, just like you would in any normal patient, except with a lot more attention to detail. One of the areas where these patients are at particularly high risk in the surgical theater is during the induction of anesthesia. It's not just the medications that we have to titrate, and there's no particular medication that's safer or more dangerous. The rate of administration, how much you give, the underlying physiology of the patient also. But the transition from normal ventilation, where the patient's inhaling under negative pressure, to particularly in emergency surgery, are you going to perform a rapid sequence induction to secure their airway in these patients? You may, after consideration, decide to prioritize their cardiovascular risk above their airway risk, whereas in a normal emergency, in a normal patient, you would prioritize their securing their airway. So instead of A, B, C, you may think C first for circulation and then airway. But then again, it's a pro-con argument with these patients. Usually when I induce these patients and we intubate them and switch them to positive pressure ventilation, one of the main things you can do is try to make that transition as gentle as possible, as gradual as possible. Start off with small tidal volumes, small pressures. The transition to positive pressure ventilation is sort of when you hear about these patients with Eisenmenger syndrome arresting on induction of anesthesia. If you titrate your induction, it's usually not the induction agents, it's usually switching on the ventilator that decreases the venous return, decreases the cardiac output in the setting of a somewhat decreased SVR that can lead to this spiraling. So how do we make these surgeries safer for these patients? Obviously, in elective surgery, you want the patient optimized as much as possible. So you want them to be as functional as possible. You want their fluid status to be good. You want to make sure that they don't have any, for elective surgery, any upper respiratory infection, But in emergency surgery, all that's sort of out the door. Your optimization or making surgery safer for these patients is going to depend on intraoperative monitoring. So in a surgery like a cholecystectomy, where you might not normally engage in invasive monitoring, you will be placing an A-line in this patient. You're going to also, to make it safe for them, your post-operative care is going to differ. Patients with Eisenmenger syndrome are not going to the PACU, and they are not going to be going home right after surgery. Even something as simple as a tooth extraction may require the patient to have an overnight stay in the hospital. I have done tooth extractions in Eisenmenger's patients where, the OMFS or the dentist was confused about why we wanted to keep the patient in the hospital. But again, the transition from the anesthetic state to being fully awake and dischargeable, you want to be gradual, and these patients want to be observed and monitored. Then again, how much are you going to invasively monitor these patients? At a minimum, you're going to, be monitoring their blood pressure a lot more closely. We have the concept of placing central venous lines, pulmonary artery catheters, which we typically avoid in this patient population. Patient coming for heart-lung transplantation, the surgery itself is going to warrant a higher degree of monitoring. But if a patient's coming for an elective, what would in a normal patient be considered a low-risk surgery, you're going to bump them up in the category of monitoring and post-operative care. Emergent surgery, you don't have the luxury of pre-optimization, so you're going to focus on intraoperative care and specifically post-operative care in these patients.
Wonderful. Thank you, Dr. Monteiro.
Awesome. Thank you. It looks like I'm going to have the next question for Dr. Ermis. And these patients usually survive into adulthood. And some of them we see are doing really well with a good quality of life. When do you start to consider transplant evaluation and referring them on to transplant surgery?
Yes, thank you. Just one moment. Let me just pull up a few slides. I think this, obviously this is a difficult question, for multiple reasons. And I'll touch on it a little bit here. And I think this slide actually kind of demonstrates some of the difficulties and some of the challenges we face. This was a slide that was published in Heart last year. I looked at had a Nordic registry looking at all their heart-lung transplants and Eisenmengers over the last, it was 2.5 decades. And as you can see, the darker areas are just lung transplants. The lighter bars are heart-lung combination transplants. And these are, and you can see, and these are all in Eisenmengers patients. I believe they had 63 Eisenmengers patients who were transplanted during that time. 57 were heart, lungs, and 6 were lung transplants. But as you can see, it was fairly high and has dropped down in recent years. And they found just about 10 or 15% were done since 2006. And some may ask, why is that the case? And I think if you go back to Dr. Madan's slides and his talk, some of that is the advent of pulmonary vasodilator therapy. And having the ability to medically treat patients in a way that was not available previous to that. The other difficult thing is, and it's not shown in this slide, the median age of patient in this group was 31 years of age, which I think is very difficult because you go back to the patient example of 56, and one would obviously argue that if that patient was transplanted with a heart-lung transplant at 31, we probably wouldn't be here having this discussion about him at 56. If you look at the next slide, which I believe is here, is you look at survival after heart-lung transplant, or overall in this cohort, in this group, which survival here is actually better in this group than reported in other studies looking at heart, lung, and lung transplant, thought to be due to just in the same ways of looking at overall comparisons, even just in heart transplant, maybe for ACHD patients, because of believed to be that this was a younger group of patients, that their survival after heart, lung, and lung transplant was better. Oftentimes, other studies have reported some struggles after transplants involving lung transplantation due to the difficulties in some of those patients. Obviously, there's a good amount of risk that this slide shows in the immediate post-op period from this transplantation. As many people have mentioned, this is a very, hands-on and difficult endeavor. Sometimes some of these patients are sicker, and you can see, the difference between mortality, because the difference between the conditional survival for those who survived at 1 year, obviously, is better. But oftentimes, I think we also just get stuck on the mortality in these patients, but there's a lot of morbidity that's associated with this, and this group showed the same thing, whether it be from a heart or from the lungs, or just the other things that come along with these. Oftentimes, patients are going into this with poorly functioning kidneys and end up requiring dialysis, either in the short term or long term. Most will require, at least from experience, a lot of times dialysis in the short term after a heart-lung transplant, if they are because they're going into that with symptoms. One of the other things to look at is the non-skin cancer risk in these patients long term was quite high. And so, I think we have to balance off the ability to do these transplants with what comes after doing the transplant, and that's where the decision becomes very, very difficult. This was a commentary from Dr. Bott up at Mass General on this article, and one of the things that we often talk about is, and that is I hear talked about a lot, is that the idea that Eisenmenger's patients do well. In general, compared to idiopathic pulmonary hypertension patients, oftentimes Eisenmenger's patients live a lot longer just with medical therapy. And then with the additional ability to utilize pulmonary vasodilators, perhaps that, has improved. The difficult part is oftentimes, just like everything else in adult congenital heart disease, the heterogeneity of the population is very, very difficult to ascertain who does well and who doesn't, because I do think there is a difference between groups, and from that perspective. Additionally, I think as we learn more about transplant, more about heart-lung transplant, and the ability to care for patients afterwards with some of our, newer technological advances, I think we will improve probably both of these curves, where there's probably is an element where the conventional therapy runs out and you have to hand off to perhaps transplantation. The question is when, and that is still a question, and I don't have a good answer to that. This was a paper that was published a couple years ago from the Canadian group with Dr. Oshlin and their group up in Toronto. And it really was trying to get to the idea of, so how do we determine prognosis in these patients? Tends to be, a lot of it, comes down to functional status. And a lot of it comes down to some laboratory markers. Tend to be those patients with post-tricuspid shunts do better than pre-tricuspid shunts. Simple patients obviously do better than complex, but I think that's simplifying it too much. I think there's a lot into those statements about when these patients present, and what that means for them. And so they actually did lay out, and this is, I've seen this kind of idea in several papers over the course of the last few years, looking at how to approach Eisenmenger's patients. And it's probably something, that is probably, in general, follows kind of my thoughts. I don't really, and they do note that this is rare. I don't think we really have a lot of really truly functional, WHO class 1 patients who are completely asymptomatic and can do all their activities, who are Eisenmenger's patients. And so we really are getting into the line of that Dr. Madan was talking about, medical therapy, whether it's single agent or tool agent, depending on your kind of how you approach the guidelines from different groups. And then in those patients who you seem to be getting towards, you're on dual therapy, they're still not doing well, their 6-minute walks are declining, their symptoms are, increasing. Those are the patients that then definitely, need a referral to not only an ACHD center. I do think, obviously these patients should have always been at an ACHD center, but an ACHD center that can, explore the ideas of heart-lung transplantation in them, because there's not many out there who can, and so I think getting them in that pathway. The one caveat I'll say to all of this is, if you have a patient that's newly to your center, and you really do need to really fully investigate their anatomy and physiology to make sure they truly are an Eisenmenger's patient. I have been in situations where I've had patients who are unrepaired transpositions of the great arteries with VSDs, who referred to us because they were Eisenmenger's, because they were desaturated, but on investigation they had a lot of branch pulmonary artery stenosis that protected your PVR, and their PVR wasn't really low because they haven't been cathed in years and years and years. And so updating their cath numbers, especially when you're approaching advancing treatment in these patients, or referral for transplant, I think is very, very important. Difficult group. I think we all kind of come at it from a little bit of a different path, but I think this kind of in general hopefully gives people an idea of some of those things that we think about. So thank you.
Thank you, Dr. Ernest. That's truly a difficult question and a challenge that we face when we meet these patients and when we take care of them, to decide the timing, are we doing everything we can, the prognosis, and having those discussions with the patient, I think it's very important too. I would like to ask Dr. Fuller, from a cardiac ACHD surgeon perspective, first just reviewing what Dr. Ernest just pointed out, from a surgical perspective, do you sometimes wish we send these patients for transplant evaluation earlier? And then number two, what clinical features or long-term complications of cyanosis and pulmonary hypertension can make transplantation more challenging for these patients?
Thank you very much, Dr. Duarte. I really congratulate you on putting this panel together, because I feel in some respects Eisenmenger's is a little bit of a kind of forgotten issue in adult congenital. We focus a lot on the single ventricles. We focus a lot on adult congenital patients who get referred for elective surgery, but not so much for these other complex patients who really present very challenging decisions for us in terms of transplantation, timing of referral, medical management prior to transplantation and on the waiting list. And then ideally, what's very unique about this population is you have a choice about how you're going to transplant these patients, whether it's going to be single or dual organ for these patients. So again, a very compelling and a very challenging population. I think what's unique about this population as well is they tend to be very well compensated. So these patients tend to do very well, or tend to have a very good, relatively good quality of life until they don't, so to speak, and they fall off a very precipitous cliff. And at that point, the question really is, are these patients too sick to transplant? So to address some of your questions, the first step, I think, is exactly what we're doing here, which is these are a relatively small number of patients, and really relying on, I think, kind of expertise among centers who perform a small number of these cases. Just to share a few slides here. Hopefully this will be relatively quick here. But as you can see, this is there. I think that Dr. Ernest showed you one of 3 very valuable studies that have been published in the last 18 months looking at patients with Eisenmenger's. And certainly we rely very heavily on our colleagues from Scandinavia with such good population data and long-term longitudinal data on these patients. In addition, from North America, this is one of the studies that was published by the group at Penn here, Christian Bermudez, who is one of our really renowned heart and lung surgeons here, transplant surgeons here. And this was a study looking at the UNOS data, and over a long time period, almost 4 decades here, you can see that there's a relatively small number of these cases done. So in terms of the population who's being transplanted, this really represents about 400 patients over 4 decades. So we're talking about a small number of patients. And one of the questions that the group at Penn posed was, realistically, are there unique features that portend better survival for those patients, either going bilateral lung transplant or heart-lung transplantation? And very similar to the results published in another US study, realistically concluded that those patients with ASDs tend to do a little bit better when they receive a lung transplant. In other words, they're patients who might be pre-selected given the fact that they have better cardiac function and are really using the ASD aggressively as a shunt. but tend to do well with isolated lung transplantation, as opposed to those patients with a ventricular septal defect who tend to perform much better when they undergo both heart and lung transplantation. And I think the key point here is there's certainly a lot about not only the cardiac morphology, but some granular details about these patient populations that we really need to try to understand better in terms of which transplant is going to offer them a better survival. Another similar study looking at an earlier era, this is again ISHLT data, and I think the most interesting part about this study is irrespective of whether you go a single or a dual organ transplant, realistically the survival is not exceptional for these patients. And I think in most studies we look at about a 10-year survival that tends to be about 30 to 40% for these patients, whether they undergo a heart transplant in conjunction with lung transplant or lung transplant alone. I bring up both of these studies simply because it really, I think, is key to our question here. Are these patients going to do better on medical management, or are we potentially, when the survival isn't great long-term for transplant, are we actually doing them a favor by transplanting them? Certainly for a surgeon, early referral is much better when we talk about the very long-term effects of multi-organ dysfunction, particularly with cirrhosis, as in your patient that was shown earlier, complications related to bleeding, complications related to anesthesia for these patients, and it becomes a very multidisciplinary team that really has to come together and make some challenging decisions on what's the best course for each individual patient.
Thank you so much, Dr. Fuller. I think there is great interest from our audience. Just following up in this, we got a question asking for you, Dr. Fuller, what are the considerations of abnormal coagulation that you take into account when proceeding with cardiac surgery in Eisenmenger patients?
Yeah, so a lot of those questions have to do with end organ dysfunction. And I think, as Dr. Ermes pointed out, the postoperative course for these patients is usually one that is quite torrid. So we anticipate that these patients may experience ventilatory dependent respiratory failure, needing a tracheostomy. Renal dysfunction is very common in these patients. So very, very commonly, they have some sort of temporary dialysis that could last up to several months after transplantation. And then lastly, I think what's really important, somewhat understated in this population, is their frailty. So the need for these patients to undergo long-term hospitalization with intensive rehabilitation after these transplants. For me, certainly one of the bigger concerns tends to be the coagulopathy that we get from hepatic dysfunction in these patients. And although there are some case reports and some centers who have done tri-organ transplantation, that's not something that I've done here at Penn, but I think that really becomes the next question, is which patients are going to get referred not only for heart-lung, but also for liver transplant.
Right. Thank you, Dr. Fuller. Yes, I think that's what you highlighted is very important in this specific patient that we discussed, that the discussion has been not only heart and lung transplantation, but also the need for liver transplantations from the liver transplant specialist's perspective. I have another question from the audience. It's for Dr. Gins. They would like to know how does Eisenmenger affect the gallbladder?
Thanks very much, Valeria. So certainly increased turnover of red cells will lead to increased bilirubin and therefore I've got a dual screen, will cause gallstones and that's felt to be the main etiology there. But these patients are also at high risk for infection because of cyanosis, and it's one of the highest risks of one of the largest causes of death in these patients is infection.
Thank you, Dr. Gins. I think we're running out of time, so I would like to take the last few minutes to thank our panelists, Dr. Gary Monteiro, Dr. Peter Ermes, Dr. Gins, Dr. Madan, and Dr. Fuller. We really appreciate your time and you sharing your expertise with us and our audience. Thank you.
Thank you.
We're gonna
Thank you.
We're gonna take a break right now, and we'll come back with our next session on the transplantation in patients with adult congenital heart disease. Thank you. Good morning and welcome to the Adult Congenital Heart Disease Symposium edition 2021 here at the Houston Methodist. We're very excited today to start with this session which we're currently learning about, and many of our patients will benefit and are benefiting as we're developing innovative ways of supporting them as they struggle with heart failure. I would like to welcome our guests today. To my right, I have Dr. Thomas MacGillivray. He's our adult congenital and transplant surgeon here at the Houston Methodist. To my left, I have Dr. Ryan Yousefzai. He is one of the heart failure and transplant cardiologists here at the Houston Methodist. And via Zoom, we have Dr. Stephanie Fuller, who is an adult congenital cardiac surgeon at the University of Pennsylvania and at the Children's Hospital of Philadelphia, and Dr. Laith Al-Shawabki, who is the director of the Adult Congenital Heart Disease Program at the University of California in San Diego. Thank you for joining us today, and without further ado, we'll kick off our session with a case. By no means this just is meant to be a representative case of the complexity that we deal with as we evaluate congenital heart disease patients for transplant, and then we'll have a panel discussion touching on frequent questions and clinical challenges that we have encountered in the care of these patients. So our patient is a 20-year-old young man who has great complexity congenital heart disease. He has heterotaxy, asplenia, total anomalous pulmonary vein return, complete AV canal with straddling chordal attachments, double outlet right ventricle, and demal post-grade arteries. He starts post a lateral tunnel fontan. We'll briefly review his surgical history. He presents for evaluation for transplantation in the setting of worsening cyanosis and worsening functional capacity at his young age. So he, like many of our patients, he had a bidirectional gland and a total anomalous pulmonary vein repair. He had some post-operative complications that require intervention of pulmonary venous obstructions, and subsequently he underwent a lateral tunnel fontan, fenestrated fontan with AV valve valvuloplasty. Over the years, he underwent several coiling procedures for aortopulmonary collaterals. And ultimately, he underwent a palliative fontan fenestration stent and a creation of an additional fenestration in the setting of failing fontan physiology with severe ascites, severe lower extremity edema, and poor exercise capacity. His baseline oxygen saturation is 74% currently, and it has been worsening over the last few months. His peak oxygen consumption is 21.7 milliliters per kg per minute, which is 46% of predicted for somebody his age and gender. Quickly touching on the MRI, as you can see, the fontan pathway is unobstructed, and here is a close-up to see the stented fenestration and the recently created fenestration, both of which are patent. Because of metallic artifact in MRI, it's harder to assess for this one, but we confirm an echo and cath that both fenestrations are patent. Here over at the right, you can see that he also has a moderate AV valve regurgitation. He has a common atrium and a common AV valve that has been intervened on before, and his ejection fraction is around 50%. he underwent cardiac catheterization as part of his transplant evaluation. We demonstrated massive collaterals from the systemic to pulmonary circulation. In addition, he has a significant amount of aortic pulmonary collaterals that are in close proximity to the pulmonary arteries and the bronchial tree. He had a Fontan pressure of 20. His lab demonstrated a creatinine of 1 and albumin of 4.4, elevated ALK-Phos and total bilirubin. He underwent a liver biopsy, which is part of our transplant evaluation protocol here, which shows cirrhosis, stage 4 fibrosis. So as many of you have grasped already, these patients present a great complexity, not only because of his cardiac anatomy, but also because of liver involvement and collateral burden. So I would like to start asking Dr. Yousefzai, from a heart failure and transplant perspective, what are the challenges that you identified at the time of listing and evaluating these complex patients? And what data do you need from the clinical and surgical ACHD specialists?
Thank you again. I'm thrilled to be part of this conversation. And this panel here, and as you saw, these patients are pretty complex, and they present very heterogeneous, and they come with a lot of complexity. So as a transplant cardiologist, when they get referral from this patient, we have challenges that we face with these patients are in a different level. The first, as we evaluate this patient, the risk stratification of this patient is it's a challenge, because the usual tools that has been identified to risk stratify these patients with the other type of cardiomyopathy, the ischemic cardiomyopathy, non-ischemic cardiomyopathy, it does not apply most of the time for an adult congenital heart patient. As you see in this graph that was published by Late actually in JAG, we should think about a CHD patient differently as far as their risk factors and risk stratification compared to the other cardiomyopathy patient that we deal with. And after we get these patients evaluated, and when they decide that they need transplant and they listing, I'm glad this society has recognized that the patient with adult congenital heart disease, they deserve higher listing. So in the new allocation system, they did upgrade them as a status 4 just by having adult congenital heart disease, which is great. But then challenge comes after that, where they are listed as a status 4, as we know, and that's very variable in a different part of the countries, depends which part of the country you are. Most of the people in the status 4, they do get transplanted, but their waiting time is very long as a status 4. So if you list this patient as a status 4, then the challenge becomes how we upgrade them to the higher status and what criteria we use to upgrade them to a higher status. The usual criteria that we use, for example, using temporary mechanical circulatory support, the inotropes might not apply or might not be possible in these patients. Either the anatomy is not appropriate for a temporary support, or they have a lot of arrhythmias. We cannot start them on inotrope. Some of these patients, they are waiting with the Swan ICU with a PA catheter. We might not be able to place the PA catheter because they have a SVC obstruction. So it's going to become very challenging to upgrade this patient to the higher status to be listed. Therefore, as has been shown in multiple studies, the waiting time for this patient on the list is higher than, understandably, the mortality can be higher while they're waiting. So, there's a big need for a more organized and registries and studies to show and have a better understanding how we can upgrade this patient to the higher status. And after they transplanted, then they become status, challenge of the post-transplant management. A lot of centers, they need a very specific management for this patient. They're complex and they have a multi-organ involvement. And even though the early survival has shown that it's not as good as patient with the non-ischemic cardiomyopathy, but the good news is after they passing the 1 year on the long-term follow-up, they do much better compared to the other patient. So this myth that this patient, this survival is not very good, that's true maybe early. That's why it's very, very important to the early surgical and medical and ICU management of these patients to get them through the initial management, because when they survive to a certain time, after that they do really, really well. So there are a lot of challenges, and that's kind of, I want bring the question back to Dr. Fuller here, that from the surgeon standpoint, when you evaluate these patients, what are some of the risks that you see, how you evaluate this patient, and then how you approach this patient, and what do you look at this patient when you re-stratify them for the transplant?
Yeah, it's a great question, and I think it's a really complex answer. I try to simplify it as much as possible. So I try to break these patients down into, how do I get the anatomy back to what would be the standard anatomy for a transplant in a patient who doesn't have congenital heart disease? So in terms of thinking of the systemic venous return, do I have accessory vessels, left-sided SVC? Is there an interrupted IVC? Number one. Number two, which side does the pulmonary vein return to? Does it return to the same side? Or is it ipsilateral pulmonary veins, for example? Does that affect how I need to do my transplant and what connections I need to make for it in terms of opening up pleural spaces, et cetera? In terms of the aorta, the sidedness of the aorta, what the size of the aorta is, what I need to reconstruct. That goes the same for the pulmonary arteries in terms of any kind of stent material, stent graft, particularly in the face of a patient who's had a Glenn or a Fontan, in which case I need to reconstruct, obviously, bicable in addition to the pulmonary arteries. So some of that is basic anatomic information. Then there's the issue of kind of, while I'm inside the chest, what's going to be a hindrance? And one of the biggest things, especially for this patient, being collaterals. And I realize it's not only the severity of the collaterals, but also what's very key is the location of the collaterals. So we consider the collaterals based on if they're in our surgical field or not, and we stratify them quite differently. You may have a patient who on CT scan, and here at Penn, we try to do CT scans every 6 months on our patients who are listed, and that's with bilateral arm injections, so that we can really see in the thorax what the contribution is from both the right and the left side of the collaterals. And realistically, if those are within our surgical field, even if they're severe, they're not consequential. It's the ones that are in the surgical field that we worry about. Lastly, from a surgical standpoint, I think the things that's really important is, kind of general good stewardship of reduced sternotomy principles. So, what's our plane in terms of separation of the heart from the sternum and the underlying structures? We do ultrasounds on all our patients of both upper and lower extremity vessels in terms of patency of vessels, so that we can look at how we're going to access the patients for cardiopulmonary bypass, whether it's going to be peripheral. Here we're particularly aggressive about using heart-liver transplantation, so all these patients are accessed with venous through their groin, and then we can either do intracardiac or we can do SVC or internal jugular cannulation for the neck itself. So a couple considerations for transplantation based on kind of how each patient uniquely presents, and all of them need to be assessed independently.
So a lot of our patients with Fontan may undergo routine cardiac catheterization, and they may have heard of the term collaterals. These are extra vessels, and they don't particularly serve a good purpose. In fact, they overcirculate the heart and may lead to heart failure symptoms. So generally, we try to address those collaterals during cardiac catheterizations. The question is, for practitioners and for patients alike, if we're doing a cardiac cath, or if we're approaching the patient pre-transplant, do you recommend that we approach these collaterals differently, maybe more comprehensively? And what are your thoughts about during the transplant itself, when you see all this return coming back from the pulmonary veins, and after transplant, do you see these collaterals becoming an issue for these patients?
Yeah, Yeah, I mean, the collaterals certainly are an issue both during the transplant and in the postoperative period for these patients. So in the ideal world, we would have a patient going for embolization of collaterals immediately preceding a transplant. So, for example, in the week or two before a transplant, have these embolized, or even in the hours before a transplant, have these embolized. Of course, one of the issues with transplantation is timing, and timing's everything. It's not predictable, and oftentimes it's not necessarily lenient in terms of once you get an offer, you have a limited amount of time to work within those parameters. I think for our colleagues who do the liver transplantation, they're much less concerned about collaterals. For example, for the single ventricles who tend to have portal hypertension. They're very used to dealing with portal hypertension and varicosities in the abdomen. But for us in the chest, as you mentioned, it really does become a concern, not only from a bleeding standpoint, but also in terms of the burden of cardiac output, particularly with the collaterals that come back in a sense during pulmonary venous return. It can really mean that we have to put some consideration into, for example, oversizing our organs, how we're going to manage those in terms of cardiac output and increased cardiac output as a result of collateral burden. Being able to coil those before surgery, and if not, making sure that we're able to do a safe operation where the bleeding risk is kind of minimalized, meaning that the collaterals are outside the bleeding risk. And it is one of the reasons, in fact, that we actually will turn down patients for transplant is the severity of their collaterals. So it really is a very important issue for us.
If I may, I mean, one of the things that's fascinating to me whenever I participate in these heart-liver transplants is that, as Dr. Phillip pointed out, the liver transplant surgeons think nothing of varicosities and intra-abdominal collaterals, and it's because they have unbelievable exposure. They have access to anywhere they want to go in the abdomen. In the chest, it's a little bit different, and I would say it's also different when you're dealing with a baby or a child compared to a big Texan. In that it can, access can be challenging with all of the other organs, and as Dr. Fuller pointed out, it's not so much the vessels that are in your field and in your face, it's those posterior APCs that are really difficult to get at, and oftentimes, these are not normal vessels. They're big vessels that arise from small vestigial vessels, and they are very fragile, they're thin-walled, they can tear and retract, and it can be very difficult to control them sometimes. So as we like to say, as heart surgeons, we deal with bleeding all the time. I mean, we don't, that's part of what we do. This, I think, goes into a special, can go into a special category or a different camp.
Yeah.
I think it's also very interesting, Dr. MacGillivray, what you astutely pointed out is, everybody comes in different sizes and shapes. And when I refer back to that CAT scan that you showed, or the MRI that you showed, Dr. Duarte, it's interesting to me. The first thing I noticed is just how deep that patient was. The anterior posterior diameter of the chest was just huge. This is a very barrel-chested patient who, where we're operating, is very deep posteriorly.
Right. Do you want to add something?
No, I was one of the I see as a challenge this patient, and as Dr. MacGillivray, Dr. Fuller mentioned, these patients they might need multiple sessions to multiple catheterization every few weeks. I always feel that when do you start that? How you determine when to start? Because this patient get listed, as we talked about. Some of them they're on the wait list for a while, with different status. They might come with arrhythmias, and they become unstable, and they might need a heart transplant sooner. When do you decide to start this coiling or blocking of these collaterals, and which one you start with?
Maybe we can ask Dr. Al-Shawabki to share with us what's the experience, the approach at UCSD, how aggressive you are with the collateral coiling, how early you start. Do you start after the patient is listed or ahead of time? And while they're in the waiting list, do you have subsequent sessions of coiling? Since these collaterals can usually come back after some time.
Thanks, Dr. Duarte. So I think just like everybody here in the panel, we are adapting to our patients' needs. And we do, in the initial cath, we do address most of the collaterals that we can address before listing. Once the patient is listed, we strive to completely eliminate all collaterals. When I say all, I mean aortopulmonary and veno-venous, because we have non-published early experience that veno-venous collaterals may reverse shunting post-transplant as you lower the systemic venous pressure. Obviously, you have to take that with the caveats of raising the Fontan pressure and may induce decompensation in these patients. So you have to individualize to every patient's need. But every 6 months, we revisit the patient's collaterals with cardiac catheterization and readdress them. As Dr. Fuller indicated, those could grow very quickly. And we're shocked each time we go back in how many more collaterals have reformed. So obviously, in patients who have higher tendency to develop collaterals, we may consider cathing them at more frequent intervals.
Thank you, Dr. Al-Shawabki. Do you have a question?
Yeah, I think kind of going back to our patient that, with the Fontan and, the failing Fontan and liver transplant this patient, so I feel when evaluating, we look at it for if they need a liver or not with the heart. Sometimes it's easy decision. They have a cirrhosis and they have all this cirrhotic stigmata. It's easy decision to transplant the liver and heart and liver. But sometimes, this patient, they don't have that full-blown cirrhosis, but we know they're dealing with this high Fontan pressure for a while. How you decide when you do heart, liver versus just only heart in this patient? Maybe the question from Dr. Fuller.
Yeah, I think there's a lot of evidence that both work very well, and by no means do I think there's one clear-cut way to do it. We've taken a particularly aggressive approach here at Penn, where we only offer heart-liver to our single ventricle patients. We found that perioperatively, these patients tend to have lower bleeding risk and complications once they're getting a liver transplant in addition to a heart. And the second added benefit is these patients, oftentimes being very sensitized, tend to have a much lower incidence of rejection for the heart itself with the liver. It tends to be very protective for them. And we're not sure exactly why that is, but these patients tend to experience, we've actually seen 0 heart rejection in our patients who have had dual organ transplant. Having said that, it's a big procedure, it's a long procedure, and it's not without any type of complications in the perioperative period. So these patients tend to have a high incidence of renal insufficiency, oftentimes requiring temporary dialysis after this operation. And second of all, these patients tend to have a high risk of vent-dependent respiratory failure, so also a high incidence of tracheostomy postoperatively. Those tend to be the 2 most common complications we have. But again, it mitigates our risk of bleeding and of organ rejection.
It's pretty interesting, and I think it speaks to the challenge that we have with congenital heart disease. If you looked at some of the objective data for this patient, his VO2 max is over 20. His BNP is 140. He has, without having a liver biopsy, you wouldn't really appreciate significant liver disease. And you would be fooled or wooed into this sense of security when in fact this guy's standing on the edge of the precipice of just completely falling apart. And so you whether or not to proceed with a heart liver transplant on this patient is one thing, and the other thing is the urgency by which you have to do it, because when these patients fail, they fail fast. And it really adds to the challenge. I think, Dr. Fuller, I mean, you really very eloquently pointed out all of the different thought processes that go into planning for the transplants on these patients. And these aren't, all heart transplant patients and certainly multi-organ transplant patients require a lot of planning. But this is definitely the varsity league in terms of just the anatomic planning of how you're going to deconstruct and reconstruct these patients. Your approach to doing that. I mean, how do you do that as a team beforehand at the time of listing? Do you do it again when the offer becomes available? How do you do it at the time of the surgery?
Yeah, so we like to have kind of what we call a flight plan in place at the time of surgery. So oftentimes these patients are referred through the Adult Congenital Heart Center, and they get screened by the adult congenital cardiologist and presented at an adult congenital conference. And that's typically where, with the assistance of our radiologists, we're able to go through kind of some of the anatomic findings on scans and really kind of do an early rule in, rule out type of process. Like, is it technically feasible? That's a separate question about whether or not they're going to be great transplant candidates, but it certainly eliminates those candidates who technically are going to be highly complex or just not candidates for one reason or another. It also alerts us to kind of what the risks are, not only with the anatomy, but with the physiology. For example, if we see a paralyzed diaphragm, elevated hemidiaphragm, that alerts us to maybe some vent-dependent respiratory failure afterwards. If we see a lot of collaterals, what our bleeding is going to be like, what our need for collateral embolization is going to be like before transplant. If we see pulmonary AVMs, what's going to be our threshold for cyanosis in the postoperative period. So there's a lot we can gather just from the anatomic imaging. If the patients kind of pass the mustard, so to speak, in that setting, then they go on to have separate evaluations with each member of our team. So that involves both, in our case, the cardiologist and the hepatologist, the heart surgeons and the liver surgeons. And we establish kind of a protocol for each patient if they are to be listed in terms of how often they're going to have repeat studies done, whether it's laboratory testing or whether it's imaging. And then we get together monthly to re-review patients, and particularly their CT scans, and the main reason being to assess their collaterals. We don't expect the anatomy to have changed, but the development of collaterals could have changed. They could be different, classified differently based on the severity of their disease and how it progresses over time. And for a lot of our patients here in the Northeast, we're looking at quite long waiting times for these patients. We document all of that into a very comprehensive document, which has the anatomic details, the type of donor that we're looking for, everything that's kind of been agreed upon for these patients, blood types, what we want available, down to the cannulas that we use for the procedure. What is our cannulation strategy? It's a very detailed operative plan, and that actually gets put into our electronic medical record and is accessible by all team members at the time of transplant. Once we've accepted organs, we actually have a huddle with the entire team, both heart and liver, both medical and surgical, and we really make an effort to include our nurses and our perfusionists as well as our anesthesiologists in that. And so everybody's kind of on the same page. And if they have any concerns at the time, it's a very detailed plan. And then, of course, although we do sequential here, the heart team goes first, the liver team follows with the chest open once we've been separated from cardiopulmonary bypass, our blood thinner is reversed. We always have a heart team available during the time of the liver in case there's any chance of decompensation, so that we're available to place that patient on ECMO, reinstitute cardiopulmonary bypass in case we need to. So it's a really super comprehensive approach, and it would be impossible without the work of kind of everybody on the team, from the administrators for the Heart and Vascular Center, who really help to gather these meetings and dedicate the nurse practitioners, et cetera, to us. Our administrative people who help to get that going, the nurses who are involved in the care of these patients, our nurse practitioners who do a lot of educating both prior to and after surgery for these patients, and then obviously the surgical team itself. It's really a team effort on both sides.
Dr. This is great, Dr. Fuller. May I take a question to both of you, Dr. MacGillivray and Dr. Fuller, regarding listing some of these patients? You are in a unique position, both of you, of being both adult congenital heart surgeons, and you do transplants. Now, what do you say for centers that have separate roles for these surgeons? Let's say you're considering an atrioventricular valve replacement or repair in a patient with Fontan. Do you think including the transplant team in the conversation early on would be helpful?
Go for it, Stephanie.
Yeah, I mean, I personally think it's always helpful. Like, the more the merrier. So we're not shy to phone a friend here, which is really advantageous. And I'm very fortunate in a sense that although I work out of both hospitals, I have really collegial relationships with all my co-surgeons at both hospitals. So it's nice, for example, when we have patients with a Fontan who need complex aortic work, I often work with one of my aortic colleagues, Nimesh Desai or Joe Bavaria over at Penn. If we have a patient who we're considering a high-risk surgical intervention for, whether it's a Fontan, tetralogy of Fallot, or a patient who's a mustard or Senning, who has complex comorbid issues and poor function, we always involve, for example, our electrophysiology colleagues. We involve our heart failure team and our heart failure surgeons so that we have kind of a backup plan for these patients. It's really advantageous. I'm a congenital heart surgeon who does heart transplant, but I've, in my career, not done nearly the amount of heart transplants that, for example, Michael Acker has done. So I really rely on the expertise of my colleagues over at Penn, and similarly in our congenital heart patients when it comes to reconstructing the pulmonary arteries, the SVCs, the IVCs, et cetera, in these patients. We work very collaboratively with each other during the time of transplant. So our heart liver transplants are always staffed by a transplant surgeon as well as myself, a congenital heart surgeon, so that we are always working kind of in unison with each other. And really, it's like the best of both worlds, I think. I continue to learn a tremendous amount from my colleagues, and I'm sure across the world, when you look at patients who do congenital heart disease and surgeons who do congenital heart disease, I think there's always a dose of humility that goes with this. And there's really not a lot of ego involved when we step up to the table. It's doing what's best for the patient. And that's a consistent kind of motto that we have here.
I couldn't agree more. I mean, in these patients, there are so many variables, and at times you feel as if you don't have enough equations to solve the problem. Mm-hmm. And as a general rule, you never want to worry alone. You want to get as many people involved, because just like Dorothy in The Wizard of Oz says, sometimes the solution is in your own backyard. And if you just go down the hall or go upstairs, something that may be sort of an unusual or a difficult problem for you to solve may be something that's very commonplace for somebody who's already on your team. So, and I think as Dr. Fuller very nicely pointed out, I mean, it's a big team, and to be done successfully, it's important to engage everybody on the team.
Wonderful. And to Dr. Fuller, you described those meetings and the complexity and the multidisciplinary nature of the attendees. Would you mind sharing with our audience how long do these meetings last to discuss one of these patients? And also on the same line, we have many in our audience, we have patients and caregivers. How many people are involved in one of these operations? Can you give us a sense of that?
Yeah, it's a great question, and I think honestly one of the biggest challenges is just finding a time where people can get together. So oftentimes, this is where you really have to have the administrative buy-in. It's a great question, Valeria, and I think it's really important that administrators understand, first of all, when you're getting a patient who has accrued 40 years of hospitalizations, surgeries, medications, it is very routine to spend over an hour with these patients in office, and particularly for a transplant consult. So this is not a high volume, DRG driven part of medicine. We're not cranking out 10 patients an hour here. This is patients who, if you see 6 adult congenital patients in an afternoon, that's a huge volume simply because of the complexity these patients have. So each of our individual consults are quite long, and that's why we have patients come to Philadelphia for about 3 days of just kind of screening, meeting with their teams, potentially having testing redone, which we understand is a huge burden for patients to have another CAT scan or another catheterization done. And even once they're listed, they have to undergo repeat studies. I think all of that helps to kind of minimize the time while the patients are together. These are often early morning meetings for us. For example, our imaging reviews we hold at 6 a.m. So all these teams are hepatologists, transplant surgeons, nurse practitioners, administrators, and surgeons are on a call at 6 a.m. to go over images, and the radiologists, which is kind of unheard of, but that's the time that everybody makes themselves available for these. In terms of our listing groups, going through the heart and then the liver listing, those are each hour-long meetings, and it can take quite some time to get through each one of the adult congenital patients. The same holds true for the transplant itself. These are very long cases. I think the earliest case we did was probably about 12 hours in the operating room. It's very routine to go beyond 20 hours for us for a heart liver transplant that a patient's in the room. And during that time, the patient usually will have about 20 people in the room once you look at the anesthesiologists from both sides, the surgeons, the perfusionists, and the nursing teams. So we have a really great comprehensive group that fortunately works really, really well together.
It sounds like 2 to 3 hours total meetings to discuss one patient for transplantation. So Dr. Yousefzai, who is present in these transplant meetings for non-congenital patients, how many patients are presented within an hour usually, for comparison?
Usually about maybe 3 or so in an hour. We be able to, so there's a definitely big difference as far as the discussion is always, is much complex, and a lot more. Not only just heart failure, adult congenital, surgeon, also the other teams. We have pulmonary, we have also pulmonary hypertension, the liver team, kidney team. So definitely the discussion is much more complex than a lot of other ischemic or non-ischemic cardiomyopathy patients.
Wonderful. So we will open now the panel for questions. We're going to take a couple of minutes breaks to add some more panelists, and we invite you to send your questions. You can text DeBakey to 37607 and then text your message with questions for our surgeons or clinical providers, and we will see you in a couple of minutes. Thank you.
7, 5.
Welcome back. I would like to welcome our 3 panelists that have just joined us. First, Ashley Reef. She's our ACHD nurse coordinator here at the Houston Methodist Adult Congenital Heart Disease Program. I would also like to welcome Dr. Iris Cedars, who is an ACHD cardiologist who is joining us from Johns Hopkins. And also we would like to warmly welcome Dr. Tony Huie, who is joining us for the first time at our ACHD Symposium from UCSD, University of California in San Diego. Dr. Huie is a transplant specialist who supports the ACHD transplant program at the UCSD. So let's move on to our next question. It's for Dr. Cedars. Dr. Cedars, timing is a key question when we're considering advanced therapies for patients with adult congenital heart disease. We often hear that patients are turned down for transplant and not considered eligible because they were referred, quote unquote, too late. But then, on the other hand, it's challenging to refer a patient to transplant when they're feeling well and when they report no significant limitations to everything that they want to do in their daily life. So how do we approach this? How early should we refer them for evaluation for advanced therapies?
Well, thanks for that great question. Actually, I don't know that there's a great answer, unfortunately. I think that decision-making regarding timing of referral for transplant needs to be individualized. Obviously, it's a very heterogeneous population, and you need to take it on a case-by-case basis. We don't have the kind of data that's available for the non-congenital heart disease population, where they know that once somebody's VO2 max has declined beyond a certain point, their outcomes post-transplant are better than without a transplant. And so we go based on a general clinical gestalt and the idea that once somebody has accumulated a number of adverse events, once somebody has accumulated a number of hits, that they probably are not going to do as well unless you change their trajectory. And so there are some guidance documents. The Action Learning Network has 2 guidance documents that I think are quite useful for practitioners, not really to be used as the be-all and end-all, but more as a direction of when you should start thinking about referral for at least consideration of advanced heart failure management. There's a separate one for 2-ventricle end-stage 2-ventricle congenital heart disease, and then Fontan circulation, due to in recognition of the unique nature of the Fontan circulation and the unique considerations that need to come into play when you're talking about referral of a single ventricle patient. So the short answer is we don't really know, but that there is some guidance available, and hopefully with better tracking, as I think somebody referred to earlier in the session, of post-transplant outcomes in this population, we'll have a better idea in the future of when we should be referring for transplant.
Thank you, Dr. Cedars. Definitely a challenging question and a challenging discussion to have with our patients. A difficult initial discussion when a patient is coming for a routine follow-up and we're following some objective parameters. Starting that discussion always, it's a tough moment for the patients, but I think it's something that we need to think about often and revisit every time we reassess our patients. I'm gonna let Dr. Yousefzai take the lead now with some more questions.
Thank you. The next question is for Dr. Huie. Hi, Tony. Welcome. So I kind of 2-part question. One more broad question. When you evaluate this patient for ACHD, what are the unique aspects that you look for evaluation that is different than other heart failure patient? And there I have one more specific question. As we know, a lot of ACHD patients, they are highly sensitized. And for audience, what does it mean is that our patient, during the time they develop antibody against the population that they would potentially receive organ from. And that's a challenge raising. And this usually happens with the patient who have multiple surgeries. They've been exposed to multiple blood products, so they develop sensitization, as is our ACHD patients, because they do have multiple surgeries by the time they are getting evaluated for transplant. How do you approach this challenge with sensitization, and if you have any protocol at UCSD specifically to tackle this problem?
Thanks, Ryan, for that question. A very challenging situation for us when we have a patient, particularly single ventricle, understanding that many of them have multi-organ dysfunction to some degree. That being said, I think anticipation and preparation of what you may encounter in the pre and post, and really the perioperative period is important so that we can really guide our therapies. We have some flexibility and ways to make patients more of an ideal candidate and really minimize risk. So I like to take a head-to-toe approach in the evaluation phase, similarly to what we do for patients that have indication because of other conditions for transplant, but really emphasizing that there are some dysfunction that may be predictable and we should really understand before transplant. So we need some type of brain imaging, particularly for single ventricle. Many of these patients may have had strokes prior to the time of transplant, whether it's because of going on pump for multiple surgeries or also the shunts they have. And we know that these patients may be at higher risk for side effects from calcineurin inhibitors. So understanding their risk for that is important. And we do imaging, typically MRI if possible, but CT scan is adequate. Because of prior surgeries, they may have restrictive lung disease or diaphragmatic weakness or paralysis. And I often tell patients that this is not necessarily prohibitive for transplant, but if we can really understand their risk for coming off the vent, we can really anticipate and guide them, and also even consider pre-rehabilitation or prehab, what we call it, where we go through pulmonary rehab and make their candidacy better for they can tolerate the surgery. Due to high central venous pressures or Fontan pressures, the kidney and the liver are both at risk for fibrosis. We know, and Dr. Full and others have mentioned the role of heart, liver transplant, but we also know the kidneys are a vulnerable organ and they can develop interstitial fibrosis, and even cyanosis alone can also contribute to that. So if we understand that that may be a complication, doing a full assessment of their kidneys. And the reason why that's important is because we may have ways to improve their kidney function before transplant, but also at time of transplant, there are different immunosuppressive regimens that may protect the kidneys to some extent. And then lastly, I do like to look at kind of together gastroenterology or their nutritional status and frailty. Many patients have had issues with absorption or malnutrition and may have a role for some patients to have enteral feeds. And then the question I always ask my colleague Laith is, can we try to wean steroids? Is there alternatives for protein-losing enteropathy so that at time of surgery they have less issues with wound healing post-transplant? And if that's an option, then we try to pursue that. I strongly think that every hospitalization has to be looked at as a sentinel event once you decided the patient needs a transplant. We don't have, like we do in acquired heart disease, therapies that are going to really change their prognosis. And the more risk we accumulate, the higher morbidity and mortality that transplant carries. So I aggressively look for opportunity to submit an exception to UNOS for higher status. And that's justifiable because we know these patients, once they get to be an extremis, they're extremely high risk for mortality before transplant, and their post-operative, perioperative risk is much higher. So I think that needs to be said. Then there's a role, and I'm not going to speak on this because I think this is a whole nother topic, but in rehabilitating the patient and other organs for LVAD. We've successfully done that in single and two ventricle congenital heart disease. And I know the Action Learning Network has also published on that. So that's something that's emerging, a bit controversial, but more to come in that space. Now your second question, I'll try to be brief, but it is a very difficult situation to understand sensitization. I look at 5 different questions that I ask is, were their sensitizing event only with their congenital surgeries, or is there pregnancy or other sensitizing events that they've had? That also will increase their risk of having antibodies. For prior surgeries, and I'll discuss with the surgeons if available that did those surgeries, what was the material used? Is the op report available? Homograft, we have multiple studies that show homograft exposure duration also as a contributor to sensitization. Have we assessed their sensitization status? So for example, was someone referred for transplant 5 years ago before they developed protein-losing enteropathy, and do we have an immunologic profile that can help guide us? And then also, is our methods of detecting antibodies reliable? in the patients with protein-losing enteropathy and hypogammaglobulinemia, you may have a PRA of 0 and feel comfortable that they're not sensitized, but in actuality, that's because we don't have enough titer, so to speak, to be able to have a positive cross match or a positive antibody screen. And those patients are inherently higher risk. And then there's also other considerations that we look at. Is there lymphopenia? Was the thymus removed at time of surgery? We know that many patients, particularly those that have heterotaxy, but many single ventricle patients have an impaired immune system that we don't fully understand, but that may reconstitute or may improve after transplant. So I also want to consider that after transplant, particularly as Dr. Fuller pointed out, if it's a heart alone and not heart liver, they may be at risk for a memory T cell response. So in summary, I don't necessarily have a protocol because every situation and scenario is very nuanced, but I will highlight that a good understanding of their immunologic profile is absolutely necessary to successfully get through transplant. And lastly, I just want to mention this does not mean that these patients don't do well. This just means that we want to fully understand their profile before we embark on a procedure, high-risk transplant.
Thank you, Tony, for that comprehensive answer. It's really helpful and definitely challenging, but as you mentioned there, especially with this new understanding of immunology and the immunosuppression that available to us, definitely has opened the option for this patient to be able to manage them and get them through this and get them transplanted. Thank you.
Yes.
Thank you. The next question is for Ashley. Ashley, from an ACHD nurse coordinator perspective, how challenging is to coordinate all this workup, especially when we have patients coming from out of town to be evaluated? How do you collaborate with the heart failure and transplantation teams coordinators? Can you share that with our audience?
Sure. I think that can be a pretty difficult undertaking. There are a lot of variables that go into that. How far does the patient have to travel to get to us? Does the patient have transportation issues? Do we have insurance issues that kind of come into play? And then what do we need to do on the ACHD side versus what needs to be done on the transplant side? So I think what it really comes down to is relationships. I have a really great relationship with the transplant coordinator that handles all of our patients. And by the same token, I have a great relationship with our CD surgery nurse, Dr. MacGillivray's nurse. So, we really work together between the three of us to really try to fit an assessment in to a relatively short period of time, especially if the patient's traveling from out of town. Because obviously, there's a pretty big expense to traveling to Houston and then, having to stay in a hotel and, never mind just the workup itself. So we have a biweekly transplant meeting where we kind of review all the patients. It's a great opportunity for me to touch base directly with the ACHD transplant coordinator. And, we kind of coordinate there when the patient's coming, and then we kind of work out the particulars in the background. And then at the same time, we have a weekly team meeting where I review with the surgical nurse, and then we also have a monthly surgical conference where we cover some of these patients. So these patients, between our various conferences really get covered several times with several different audiences. So I think, from my perspective, the way we have things set up has made it relatively easy. But it is about those relationships and really having resources. We have some great resources that can help some of our patients financially that are maybe struggling with making the trip here. We have a great ACHD social worker that she just works miracles. And then there's also, the resources within the transplant team. So, we're very blessed to have a great team that works together so well and to get these patients to Houston, even if they are relatively far away. So I think we can do a pretty expedient workup and, have these people ready to be listed for transplant pretty quickly. So I think those relationships are just really important, and getting the patients to Houston.
Thank you, Ashley. Yes, definitely collaborative work really helps optimize the itinerary for these patients when they come, and optimize their time, the use of their time and their resources too. I'll let Dr. Yousefzai take the lead again.
Thank you. So next question is for Dr. Fuller. Dr. Fuller, so we know, as we mentioned multiple times in this talks, that these patients are unique, they have their own challenges. One of the challenges that we have, that we need to encounter, the immediate post-operative management of these patients and the expertise that we need with the ICU team to take care of these patients. What are your experience, and what are the some of the immediate post-operative concerns and red flags for you that you look, and what are the how you manage them?
Yeah, thanks for that question. It's obviously really imperative to us that we have a really great team from anesthesia and intensive care. So at Penn, our intensive care unit is staffed by a combination of cardiac anesthesiologists as well as intensivists. So both of them work together to kind of help us in terms of patient management. And then I think what's really important is there's also the involvement of not only the ACHD cardiologists, but the heart failure cardiologists and the surgeons on both sides. In addition, we have the luxury of having, EP available, cardiac catheterization available from both hospitals. So if a patient encounters particular difficulty where, a stent is needed, embolization is needed, a patient has an EP need, it's very easy to kind of quickly gather the resources and work in a multidisciplinary format to address the needs of the patients. Recovery is something that's a challenge, and we stress that to the patients preoperatively. And I think Ashley really brings up a great point here, which is that kind of team approach is critical, but also a lot of transparency with the patients in terms of what to expect post-operatively. It can be a very challenging recovery. We have a high incidence of tracheostomy and renal failure requiring dialysis in the patients who undergo dual organ transplants. So making sure that the patients are kind of going in with their eyes wide open in terms of, hey, the transplant might go great and we might get up to the ICU, and it could still be, in many cases, weeks in the ICU of recovery. And to some extent, that's where kind of the point that Dr. Huie made about, really prehabilitation and making sure the patient's in the best condition possible prior to transplant, I think is ultimately going to help us on the backside when it comes to managing these patients. But it really takes a comprehensive team that's quite dedicated and very alert to any of the potential issues these patients will have.
Thank you.
Thank you, Dr. Fuller. I think what you mentioned, that we should give the patients a heads up as we're discussing transplantation, that it's a journey and sometimes it's a complex one. Not only the post-transplant recovery, but also the pre-transplantation wait sometimes in the hospital. So that's we have learned with experience that they appreciate and do better and handle those days and weeks better if we discuss this ahead of time. We have a question from the audience that we haven't touched on before for Dr. Fuller. Do these complex anatomies require different strategies at the time of harvesting donor organs?
So a great question, and yes, that's part of our kind of preoperative flight plan for the patients. For example, patients with a dilated aorta and aortic arch, if we're going to use kind of donor tissue to perform our aortic anastomosis, that means that we usually take aorta down to the descending aorta, for example, from the donor. If we have a need for additional or For example, if our recipient has bilateral SVCs, then we need additional length or conduit of the SVC, and we might take a nominate vein, for example. So oftentimes there are some considerations towards the donor. I think probably the most important thing to stress here is timing. So when we have a team or multiple teams at a procurement, whether it be our own heart and liver team in additional to other intra-abdominal surgeons or potential lung surgeons who are at the procurement, I think the most important thing is that we're all very communicative routinely regarding timing. So oftentimes, as you know, for congenital transplant patients, this is often their third, fourth, fifth, sixth sternotomy, and it can be challenging to actually perform the recipient cardiac explant. So making sure that we have the timing squared away with regards to the other teams in terms of, hey, we need a little bit more extra time here before we're ready for you to cross-clamp at the outside institution. I think that's really one of the most key things for us. Oftentimes we will use some synthetic material to reconstruct the hearts and the thoracic structures in these patients, but it's always nice to have some kind of backup donor tissue if available.
Great, thank you so much, Dr. Fuller. Next, I have a question for Dr. Al-Shawabki. What extracardiac or long-term issues we need to pay attention to pre- and post-transplant in these patients from an ACHD cardiologist perspective?
Thank you, Dr. Duarte, for this great session. Maybe I'll take a segue first and then answer your question.
Please, go ahead.
Dr. Huie had mentioned, which is prepping the patient. I find it much more helpful to have the patient meet our advanced heart failure transplant team before they consider listing or formal workup for transplantation. So when we detect any high-risk features for that patient, for example, moderate or greater systemic ventricular dysfunction, where the patient has been admitted with decompensated heart failure requiring IV diuretics. That's, as Ari mentioned, this is a sentinel event. So you have to take that and consider involving the advanced heart failure team. And that gives them maybe months up to a year or two to get to know the patient, get to know their special needs, answer their questions. And here they do a great job at pairing patients with those who have undergone the same process in the past, because it could be very overwhelming for the patient and family alike. So going back to your question of extracardiac manifestations, not a lot, but if they're there, they could be very important, particularly those that have to do with vessels. So great arteries, branches from the aorta that had been ligated or had been manipulated in childhood. So those things are important. Let's say somebody had an isolated left subclavian artery, and that patient is 2 or 3 years out of their transplant, and they're considering looking at the coronaries for vasculopathy. Don't go on the radial artery. A lot of these things sometimes have to be clearly delineated into their chart as long-term consequences of their congenital heart disease. Similarly, for those with hypoplastic left heart, for example, history of coarctation. The coarctation or aortopathy is still there. So for those patients, actually, we continue to see them, who we think that the ACHD team could contribute to their clinical outcomes long-term.
Thank you, Dr. Al-Shawabki. And I think with that, we're going to end this session. I would like to thank my panelists. It's been an outstanding and enlightening discussion. I think we all learned from each of you, and I hope you can join us again next year. Thank you.
Bye. Thank you very much.
Thank you.
No.
All right, welcome back. We're about to start our next great session on arrhythmias and adult congenital heart disease. I'm super excited about this because we have a fantastic panel with us today to cover this very complicated but also extremely important subject. To my right, I have Dr. Stephanie Fuentes, who is one of our third-year fellows going to electrophysiology with a special interest in adult congenital heart disease and electrophysiology. And then on my left, I have Dr. Amish DeBakey, who is our electrophysiologist with a special interest in adult congenital heart disease here at Houston Methodist. With us online is Dr. Wilson Lamb, who is also now an adult congenital heart disease specialist, who is also an electrophysiologist as well. And also we have Dr. Santosh Upu, who is an adult congenital heart specialist and also an imager at University of Texas, Houston. And then finally, and most importantly, we have Sean Fontenot, who is a cardiovascular nurse, but also happens to be an adult congenital heart patient with, I would say, probably more experience in this field than any of us here. So without further ado, I'm going to have Dr. Amish DeBakey kick it off for us.
Hi, so I'm going to start with a very, very brief just sort of overview of what we're going to be talking and what are some of the issues in arrhythmias and congenital heart disease. Mostly we're going to then follow by going over some examples of problems that we've all encountered, and we'll be taking turns talking about these. And at the end, I'm going to try to bring up some really new, exciting technologies and techniques that I think will change the future. So really, arrhythmias are a major cause of hospitalizations and late mortality in this population. It's also true that what's relatively benign in the general population as far as arrhythmias are concerned is usually less benign in some of our congenital heart disease patients. Some of the important things to realize is the differences in a congenital heart disease patient are not just structural. There are electrical differences too. The many repair surgeries that patients get can affect the conduction system or the sinus node, the intrinsic pacemaker that we're born with. We know that some patients have septal structural abnormalities that can lead to conduction system abnormalities, like a right bundle branch block in many patients. We know that scar from surgical repair creates the environment or substrate that allows for reentrant arrhythmias, where electricity goes around and around a patch of scar and creates a very fast arrhythmia. This can be true in the upper chambers of the heart, the atria, or the ventricles. We know that ablation procedures can oftentimes be quite challenging and really require individualized approaches, because even two patients who both have, for example, Fontan palliation surgery will be fairly different from each other. We know that pacemakers and defibrillators oftentimes require quite interesting and challenging and creative approaches in these patients, and just due to vascular access and issues like that. So without further ado, we're going to turn this over to Dr. Fuentes Rojas to talk about a tetralogy of Fallot patient.
Okay. So let's start with tetralogy of Fallot, which would be one of the most common defects that we will encounter during our career. So this is a 64-year-old gentleman who was born with tetralogy of Fallot, and he had a VT shunt at age 4 and subsequently underwent a full repair at age 8. So as a consequence of his primary defect and his repair, he has developed severe pulmonary regurgitation, and as a consequence of that, he also has severe RV enlargement. To complicate things further, he was recently diagnosed with a GBM, or was diagnosed with GBM, and so he underwent subtotal resection, and that was unfortunately complicated by ventricular tachycardia that was sustained and required cardioversion and an ICD placement at an outside hospital. So in that context, he was referred over to us in clinic for evaluation.
So we have some imaging studies, and I think Dr. Upu has kindly offered to explain some of his imaging.
Okay. Can I see the slides, please?
I have the slide up on the presentation.
Thank you.
Okay.
So here is the initial data. There were 2 MRI studies that were done in 2019 and 2021. And this is the basic information. And just to go over, there has been an increase in the right ventricular end diastolic volume with an indexed end diastolic volume of 124 in 2019, which is elevated to significantly higher numbers on the recent MRI, which was 146 ml per meter squared. The function, as you can also see, has reduced. The right ventricular ejection fraction went down from 52% to 43% on the most recent scan. You can also appreciate that the left ventricular volumes, although within normal limits, the function has decreased in 2021 when compared to 2019. The left ventricular ejection fraction is 48% on the most recent scan. The pulmonary regurgitation, which we'll see in the next few images, has increased from 30%, which is moderate in range, to greater than 40%. On the most recent, it's as close as 50%, so which is severe regurgitation. All these changes happened in 2 years. If you go to the next slide, please. So this is a cine SSFP, or steady state free precision imaging, and this is the bread and butter of the cardiac MR imaging, where we can quantify the volume, evaluate the function, and give the numbers that I have discussed before. And these are the images from the BEST study, and as you can see, the right ventricle is dilated, and we are not seeing the pulmonary valve on these images, but again, this is performed to quantify the ventricular volumes and function. If you go to the next slide, please. So this is focused imaging of the right ventricular outflow tract from 2 orthogonal views. The one on the left is the right ventricular outflow tract in the sagittal plane, and the other one is the one from the axial views. Again, the nature of the surgical repair was not very clear, but you can see there is some tissue within the expected location of the pulmonary valve. But as you can see, there is also some mild aortic insufficiency. There is flow going forward across the pulmonary annulus, but you will also appreciate there is significant regurgitation. If you go to the next slide, please. So this is the way we quantify the regurgitation across the pulmonary valve. We use the phase contrast imaging, and on this patient, the regurgitation fraction is severe, estimated at 49%. Next click. And you can also appreciate there is, go back to the slide, please. Thank you. So the one on the graph on the left shows antegrade flow across the pulmonary valve, and then the flow below the baseline is the regurgitation. The flow that's going antegrade in late diastole, the one which is highlighted, is due to the atrial systole. So this we see in patients with stiff right ventricles. Next slide, please. So this is first pass perfusion imaging performed at rest. And if you look at the images at the basal slice, mid-ventricular, and apical level, you don't see any filling defects. Again, this is not a stress perfusion imaging, this is a rest perfusion imaging. But there are no baseline problems. Next slide, please. So this is delayed enhancement imaging, which is done about 10 to 15 minutes after the contrast is given. As you can see, the highlighted areas, there is positive delayed enhancement in the right ventricular outflow tract, mostly in the pulmonary artery area anteriorly, as well as the inferior insertion points at the mid-ventricular level and the apical ventricular level. This is something that is very typically described in patients with repaired tetralogy of Fallot, as well as those with hypertensive dilated right ventricles. Next slide, please.
Okay. Thank you, Dr. Upu.
Thank you.
Before we go on, maybe we can just summarize so far what we know about the patient. So this is a 64-year-old man who had his first surgery at age 4, which was called a biloctosic shunt, which is a classic surgery which takes the subclavian artery and hooks it up to the pulmonary artery. We do now think that does create some risk for future events, and we'll talk about that. Later on, he went his full tetralogy flow surgery, which predisposed him ultimately, as more than 90% of our tetralogy flow patients, to a need for pulmonary valve replacement because of severe pulmonic regurgitation, so leaking of the pulmonic valve. And then in addition to that, he developed severe right ventricular enlargement in a very rapid time in the last couple of years, but it was always destined to do so as a result of that pulmonic regurgitation. Unfortunately, one of the unusual things that sometimes we do see is that he developed cancer, a brain tumor called glioblastoma multiforme, which is a very severely aggressive form of cancer. And then finally, and most recently, he developed a life-threatening arrhythmia called ventricular tachycardia that required emergency treatment with electrical DC cardioversion. And then that's how he ended up coming back to see our team here. So Dr. DeBakey.
Well, so we then performed an ablation procedure sometime after his defibrillator had been placed. So I'll let Dr. Fuentes-Rojas talk about this.
So we're on to EP lab, and as you can see in the voltage map shown on the left, if you think of healthy tissue as a magenta color and scar tissue as a red color, and you see the right ventricle and then the right ventricular outflow tract. So as Dr. Upu mentioned earlier, there was scar in the RVOT, which makes sense with his anatomy and the prior repair. But what was interesting is whenever we, in the electroanatomic mapping, we changed the scale so that the scar tissue would be labeled as 0.20 compared to 0.5, we saw this channel in the RVOT extending from medial to lateral that sort of pointed to a perfect setup for ventricular tachycardia. So that's what we targeted. So in this EGM, that's essentially sinus rhythm, and if you see the arrows where the CS catheter is pointed to, we see not just really wide fractionated signal in the there, but we also see late potentials that are significant of or suggestive of scar. Again, the perfect setup for ventricular tachycardia re-entry around that circuit. So we proceeded to ablate in that area. During the procedure, he spontaneously had an idioventricular rhythm that was similar to his clinical tachycardia, and so we proceeded to ablate in essentially a circumferential lesion along the right ventricular outflow tract, so that as to minimize conduction from the right ventricle above into the RVOT, and therefore prevent any potential arrhythmias there. And that was particular in consideration because this patient, when we were discussing with his given comorbidities of the recent brain tumor and the options that we will have for treatment, meaning surgical for the pulmonary valve regurgitation, an option would have been to do surgery versus transcatheter repair. He was being considered for transcatheter repair, which one of them would be the Melody valve, or which is the other option would be a harmonic valve. But if one were to place those stents before we were to have ablation, it would sort of be a physical barrier to being able to deliver appropriate lesions. So this was a case of ventricular tachycardia before repair of the pulmonary valve. So next, Dr. Lam will talk about a case of ventricular tachycardia after pulmonary valve replacement.
Wonderful, thank you so much. So I'd like to share with you a 58-year-old gentleman with tetralogy of flow. He also had a classic shunt placed just after 1 year of life before his complete repair at 2 years of age. And it wasn't until 5 decades later that he ended up needing a surgical pulmonary valve replacement for severe pulmonary insufficiency. Just recently this past year, he was at the golfing range and he ended up falling to his knees, slumping over, He believes he remembered himself going down, but when EMS had arrived, they found a wide complex tachycardia when they placed on the automatic external defibrillator, advising a shock. It delivered it, and we had return of spontaneous circulation, and his mentation improved on his way to the hospital. He didn't have some of the other classic factors. His EKG QRS duration was less than 180. It was 164. On his last echocardiogram, his RV systolic function was only mildly depressed. He only had mild to moderate insufficiency from his surgical pulmonary valve. His LV function was preserved, and his last MRI also had just those insertional delayed enhancement, not a high percentage of replaced scar. And we ended up doing a very similar type of ablation. When we mapped, you can see a lot of the outflow tract, which is that red zone, is scarred up already. We ended up placing reinforcement lines, but as we drew an anterior line from the outflow tract scar to the tricuspid valve, that's where we actually encountered a lot of ventricular ectopy. This patient was previously treated at an outside hospital and had a negative EP study with ventricular tachycardia stimulation, extra stimuli, and so they weren't sure how much of this was an inducible reentrant arrhythmia. Some of the studies have suggested that up to 1/3 of the arrhythmias may not be reentrant, but they may actually be automatic, and they may be a focus of electrically activated cells. And that's what we found when we drew our line from the outflow tract to the tricuspid valve, is that we got significant ectopy. One time while we were mapping, it became a stabilized VT that required shock, unstable VT that required shock, a sustained VT. And then while we were ablating, we had this similar arrhythmia that terminated with ablation. And we're hopeful that that will reduce future likelihoods that this person would require ICD shocks. We completed lines on the posterior side from the pulmonary valve down to the residual VSD patch, and oftentimes it's suggested to go from that VSD patch back towards the tricuspid valve, although the conduction system lies there as well, and you may induce heart block, so sometimes those lines are left incomplete, and that's what we did. We did a partial line from the VSD patch towards the tricuspid valve. Because this patient presented with aborted sudden death, and the original papers thought that you eliminate about 80% of the VTs just by empiric lines. Again, about 2/3 of them are thought to be reentrant, maybe 1/3 of them being automatic. We went ahead and placed a defibrillator at that time, and a dual chamber because of the possibility of atrial arrhythmias and his bradycardia that he had when he had already started up on beta blockers as well. So that's kind of what these pictures depict. On the next slide, these are the classic lines that were shown in Circulation 2007. Dr. Zeppenfeld, Dr. Stevenson from the Boston group, and it's lines from the tricuspid valve to the outflow tract patch is the most common one placed. If you already have a surgical valve, oftentimes the second line from the patch up to the pulmonary valve has already been addressed because that is scar tissue. But in people where they don't have a surgical valve, oftentimes you will have to reinforce that. The third line usually comes from the valve down to the VSD patch, and the fourth line from the VSD patch to the tricuspid valve. And so those empiric lines, or in combination with an EP study, ventricular tachycardia extra stimulus study, can oftentimes predict, have we done some good to reduce those arrhythmias? And really the decision making that goes to the patients is, do you want the defibrillator? Do you want the ablation? Or some combination that may reduce the times that you get a shock? In my practice, usually if they're presenting slumped over or requiring a defibrillation cardioversion, then most likely you're gonna want to have that defibrillator in them, particularly if they're an older patient as well, because they're gonna have other reasons for sudden death as well, such as coronary disease, although his coronaries were clean. The younger patient who may not want indwelling therapy, such as defibrillators that need battery changes every 7 to 10 years, might opt for a ablation strategy first, particularly if it's more hemodynamically stable, it's not as fast, doesn't last as long. That may be more of a reasonable approach. But I really like the demonstrative case that Dr. Fuentes, that you've shown from the Methodist, because if you do cover it up with that stent, you can't get there with your catheters. There are some techniques like Washington University have shown with stereotactic external beam radiation to try to address some of these tissues that may be covered up, but it's not routinely available at many centers.
And Dr. Lam, that was an excellent discussion about VT or management of VT once it has already happened. But in patients that have tetralogy flow with pulmonary regurgitation and RV dilatation, I was wondering if you could share your management strategy for primary prevention of ventricular tachycardia and sudden cardiac death.
That is an excellent question, and it's definitely one that's under a lot of discussion and debate. I know that the Pediatric and Congenital EP Services, the PACES arm of the Heart Rhythm Society, is actually investigating this, looking at all the different practices that different institutions have. For example, if you have a hemodynamic lesion such as pulmonary insufficiency, should you remove the pulmonary insufficiency first and see if the heart reverse remodels, and will that reduction in stress and reduction in pressure improve the VT substrate? It's possible, although when they did it with only Melody valves, they found that the ventricular ectopy was still present unless you put in lines. If you look at older surgical series, when they did the surgical valve replacements, maybe they were also excising some of those outflow tract scars or putting in empiric ablation lesions for VT, and that might be reducing the VT burden. So I think the question is still out there: should you address it with an EP study ablation first, or should you reduce the hemodynamic duress first? In the past, we've done a lot of reducing the hemodynamic duress, but if it's done with a catheter-based approach, you may block off your opportunity for ablation. And so if you are going with a percutaneous route, it may be more prudent to address things from a catheter-based EP style before deploying the valve, unless you have stereotactic external beam ablation available.
So before we move on, I think it's probably a good idea for us to go ahead and get Dr. Upu and Sean to both comment on their thoughts from this standpoint too, because I think this is obviously a multidisciplinary discussion for how we manage these patients. So Dr. Upu, why don't you start?
Yeah, so yeah, it's a great case. Very nicely, the images of the EP study were great. So one of the questions I have is, if let's say, you have described for the second patient, if there is an adult EP person, adult EP lab who does the study and does not find any evidence of excitability, what would you recommend?
That's a great.
Go ahead.
So. I think some people start off with medical management first, either beta blockers. We prefer not to step up to heavy gun antiarrhythmics like amiodarone because of their side effects. If you're uncertain, you can absolutely go with loop monitors. Implantable loop monitors may be able to detect shorter runs of VT, but if he has another real deal one, then that might leave them vulnerable for another syncopal or possibly sudden death or aborted sudden death type episode. Some people go with an external wearable defibrillator, such as the Zoll's Life Vest, and that can at least give you protection as well as monitoring while we let the dust settle. However, these episodes may not happen within a 1 month, 3 month period. So the question is what type of longevity to give them with a temporary solution such as a life vest, which can get a little bit costly after multiple months of watching. So I think if we do have a negative V-stim, a lot of times you're asking yourself the question, how real do we believe it was? Was this wide complex tachycardia? Was this atrial fibrillation with rapid ventricular response that could give you a very similar type appearance? And so that's a lot of the questions and debate that would go on with those minds.
And then Sean, why don't we have you step in here and sort of give us your thoughts on this? I mean, you've been through a lot at this point in time. If you were to sort of step into one of these people's lives and you were contemplating the question of, well, should I get a defibrillator? Should I go for an ablation? Should I get my pulmonary valve replaced first? You know, because you obviously walked through that sort of scenario. What were your thoughts when you were sort of presented with options?
Yeah, I mean, it's definitely a tricky situation to kind of, like Dr. Lam was saying, you know, is it the hemodynamics causing the VT or, you know, what other arrhythmias, or is it primary arrhythmia? And, you know, nowadays you can kind of see where some of these arrhythmias are coming from and see if it's a place you can get, you know, do an EP study and try to get rid of the focus. And as a patient, having had VT before and now a defibrillator, I think my choice would always be a defibrillator. But granted, I'd always, discuss with the physicians and see what they think the best course of action is for that particular time, and what's going on hemodynamically as well. The case is kind of still out, like prophylactically treating, especially TETs with YQRS, and how to do they need a defibrillator like we were just talking about, or other EP studies and VSIM studies and things like that. So as a patient, I think you always want to be safe and be cautious, and my vote was defibrillator would be a defibrillator, especially if you've had a documented VT or syncopal episode with some kind of ventricular arrhythmia.
And then I think I'm sorry, go ahead.
I was going to say, one of my old doctors I used to work with would always say that save is kill on a playground.
Yeah. And then I think if I can just sort of throw in my sort of 2 cents from an interventional perspective, I think the transcatheter pulmonary valve system is going to really sort of change the way we're doing things as we have more and more advances. So Dr. Fuentes mentioned that there's now the Harmony valve that's now on the market commercially, which is a self-expanding stent that should allow us to treat a lot more tetralogy flow patients prior to their first pulmonary valve replacement surgically. Along those lines is going to be another self-expanding stent prosthesis that's going to be coming along the line, and that will probably hit the market pretty soon as well, and that's going to create a lot of problems. Both those devices are going to extend our ability to do transcatheter pulmonary valve replacement, but also create some serious problems for our electrophysiology colleagues to get under there to get to the RVOT. So I do wonder if, as the treatment options start to shift in terms of this field, we're going to have to also shape the way we address the electrophysiologic issues and consider aggressive upfront ablation strategy in order to get there before that option goes away. Because although I love to shout out to my alma mater at WashU and my actually my co-fellows who actually did a lot of this work, shout out to Dr. Kuklich, it's not really widely available to actually do stereotactic radiation therapy in a lot of centers to this level of sophistication. So I do think we're going to have to start thinking creatively as a team together about how we address these issues.
Yeah, no, thank you. And I think this has been an amazing discussion. I think this is a real decision-making dilemma that is going to become harder and harder as we have more and more patients who are getting these types of valves. I really think that my belief is that we probably really do need to do an upfront aggressive substrate ablation before these types of stents are put in. In the patient that we had shown, we basically rendered that entire area of the outflow tract. A lot of the areas we ablated were actually above the pulmonic valve because there is actual muscle there that participates in VT. We rendered it completely non-capturable by pacing, and that was sort of the endpoint that we felt would be necessary if he had gotten a melody valve or something like that. We wanted to be sure that we were not going to have to face this dilemma. And stereotactic beam radiation will be a great option for these patients. I think it'll be really useful, but at this point it's still sort of a new therapy, and we have to be careful that we can't assume that it's going to be available in the time frame that we need it to be. So I'm going to go into another type of example, another type of arrhythmia dilemma. This is going to be a patient with detransposition of the great arteries and an atrial switch, and Dr. Lamb will have a case after this that's similar. We have a 40-year-old gentleman who has severe RV dysfunction, heart failure symptoms. He has an SVC baffle obstruction. He's listed for transplant, and he's been having very frequent and poorly tolerated runs of intraatrial reentrant tachycardia that got him in the hospital and pushed the decision forward to really getting listed. He's had 2 prior ablations in the past, but is still having a lot of these arrhythmias. So he went for an ablation procedure. Now he's got a very tenuous heart. We were prepared to provide some hemodynamic support with a systemic ventricular continuous flow support device, an Impella, just in case. We ran into our first challenge. This is a common problem that we encounter in congenital heart patients. who need femoral vascular access, they've had many procedures over their lifetimes, and sometimes veins get occluded, as is the case over here. The femoral veins occluded. We overcome that by getting into the collateral and getting into the vein. But our next challenge in these patients, the disease is on the wrong side of the heart, usually from where we end up in the heart. So we end up in the chamber where blue blood goes, and we need to get to where red blood is. And we do transeptal punctures in these patients, just like we do in normal population for other procedures. But the puncture is generally going in the wrong direction as far as fluoroscopy is concerned. And so this is an example. We ran into this problem where these grafts that we're going through can get very stiff and calcified over time. And we, in this case, had to do a balloon septostomy in order to allow our sheath to get in. This is a balloon being inflated, and this is a balloon being inflated. Once we got through, this patient had actually what was very quick, straightforward to map. We did not have to leave him in this rhythm for very long. This is his flutter. He was in this intra-atrial reentrant tachycardia. Every time the wave of electricity was going around and around the small patch of scar, which I can hypothesize was from maybe an appendage cannula that was put in during one of his surgeries. Every time it made one loop, it was trying to give him a heartbeat, but it was going fast and causing problems. So we were able to ablate it fairly straightforwardly by creating this line of ablations down to the non-electrically active part of the septum. And this slowed and then terminated the rhythm. And he's been free of any arrhythmias for a couple of months waiting for a transplant. Here, Dr. Lam has a intra-atrial reentrant tachycardia case. I'll let him take over.
Sure. So this 31-year-old with a double inlet left ventricle, the L-transposed great arteries, initially had a shunted circulation because of inadequate pulmonary blood flow, followed by the bidirectional Glenn, where the superior vena cava is sewn into the pulmonary arteries, and a completion of the lateral tunnel fontan, or the intra-atrial tunnel fontan. Later, the patient ended up getting a dual-chamber epicardial pacemaker, more for sinus node dysfunction, although it had a periodic AV block. And then over the last year, had cardioversions and multiple pace terminations of the atrial tachycardia that had developed really aggressively over the past year. Next slide, please. And so here is a copy of that electrocardiogram, and looking at it, you might think to yourself, wow, this person isn't super fast. It looks like it's just roughly maybe 125 beats per minute. Could this be a sinus tachycardia? But remember, this patient already had a pacemaker placed for sinus node dysfunction, and a lot of times the scarred down atria don't show you very large P waves. Interrogation of her device showed that she was in a 2-to-1 atrial tachycardia atrial flutter, which we could then pace terminate. And then what we did is when we went up and mapped using the mapping system, again, red tends to be the scar tissue. So the lateral tunnel is a lot of the scar tissue that leads up into the superior vena cava, the pulmonary arteries, and the innominate vein. We did transeptal, just as Dr. Dave had shown with the mustard baffles. We do the same thing with the lateral tunnel baffles. And then the purple tissue is kind of the healthy tissue that we would see. And our ablations were put in what would have been the usual place that we see flutter, the cavo-tricuspid isthmus, or the cavo right AV valve isthmus. And you can see those red dots that are placed on the inferior line as it backs off. And this is another case of a similar fontan, also with the lateral tunnel, with a very similar tachycardia. And you can see the wave of activation as it goes up and around. Again, some of it going around this lateral atriotomy scar, and also involving the tricuspid valve. So looking to where we can put some of our lines, whether it's on the inferior isthmus or sometimes along the lateral atriotomy, trying to cut through that circuit ends up being effective to try to reduce their arrhythmias. In some patients, I think this patient in particular had recurrences, and this was actually kind of our third attempt at it. had a very calcified conduit, and there were definitely areas of the atrium that we couldn't get to that were beneath the conduit. So these are some of the times where you might go to your congenital surgeons and say, look, would you be able to go in, do a maze procedure, and redirect that conduit externally, perhaps an extracardiac conduit, so that you can get to some of the tissue beneath the calcified conduit, and at the same time place a pacemaker for this patient that did not have an epicardial pacemaker to do pace termination. Some of the newer algorithms, particularly with the Medtronic system called the Minerva pacing, is an anti-tachycardia pacing algorithm that can be beneficial in complex congenital heart disease when it recognizes 2-to-1 flutters, or something that where there are more atrial signals than ventricular signals, and it can try to pace terminate those arrhythmias.
So I want to translate real quick something that you just talked about that's really important for a lot of our patients, and that is this concept of pace termination using your pacemaker. Do one of you guys want to jump in and explain this?
Yeah, this is a technique that has really historically been used in many, many patients. Almost everybody who has a defibrillator, the defibrillator has the capacity to spare a patient a shock. When a patient is in a rapid ventricular tachycardia, the defibrillator will try, by pacing a little bit faster, the activation of the electricity going through the ventricles can block the ventricular tachycardia from continuing and terminate it. It doesn't always work, but it can. In atrial arrhythmias, this is something that's also been around for a while. There's right now one type of pacemaker, the pacemakers made by Medtronic, that offers this capability. It is not always successful, but when it works, it's very useful. And the nice thing about it is, if it doesn't work once, the pacemaker is patient. It can try, hundreds or thousands of times. It will usually be able to help.
So does it do this automatically? Like,
it is.
If the patient's at home,
if you're asleep and you go into the tachycardia, the pacemaker will, without any outside intervention, on its own, automatically, if it's programmed to, try to pace terminate. And we control the settings, we control whether it will do it and how often and at what rates, but it is completely automatic.
So that sounds almost too good to be true. What are the risks then of actually having a device that can do that automatically?
There's not much in the way of risks. We never enable that feature when the leads are brand new, because if the leads, unfortunately did dislodge and they went into the wrong chambers, then this is not a good thing to pace the bottom of the heart very fast, unless the patient's in a ventricular tachycardia. It's also something that potentially could drain the battery if the pacemaker is going to do this tens of thousands of times per year. Otherwise, in most people, if we think that there's a chance that when it paces fast it'll lead to a rapid pulse, we would shy away from enabling this. In most people, if we're enabling this feature, it is really without much consequence. It is only a net positive.
Gotcha.
Because the alternative is, if it paces it fast and the heart goes into atrial fibrillation and we weren't able to stop it with a pacemaker, we probably would have brought the patient in to cardiovert them already. Right. So the hope is that we can stave off a cardioversion if the pacemaker can do it itself.
So that actually brings me up to the next question, which is that we're talking a lot about being very aggressive about atrial flutter, or intra-atrial tachycardia, and atrial fibrillation in transposition patients in Fontan. Dr. Upu and Sean, why do we worry so much about this? What's the consequence of leaving one of these patients in atrial fibrillation or atrial flutter?
So the Fontan population is very special, as we already know. We are all struggling with managing those patients, especially when they become adults, and if they have electrophysiologic problems, that's a nightmare. From the hemodynamic standpoint, the Fontan patients are already a low cardiac output setup. They're very dependent on the preload, and any rhythm problems, especially tachyarrhythmias, can make the heart eject even less. So especially if the rhythm problems are long-standing, they can create a chronically low output state, and that can make the hemodynamics worse. They can make the patient feel worse, and overall can have hemodynamic issues with increasing Fontan pressures and downstream structural problems. So that's one of the major things that is always in the back of our mind. And another thing which we all keep in mind is it's very common for the Fontan patients to have sinus node dysfunction, as Dr. Lam has already mentioned. And so it's important to carefully evaluate these patients to make sure that they are not in some kind of fast atrial arrhythmia, which might be misinterpreted, like the example he has shown already, and to be very aware of this. And this is something that one should be watching very, very carefully.
Sean, any comments?
I would say one other thing that you want to watch out for with particular atrial arrhythmias is clot formation and the risk of embolism and things like that, especially with AFib. I know you see it all the time on TV. People in AFib have a higher risk of stroke, so that doesn't go away with our adult congenital heart disease population as well. And due to their surgeries and history, some of them are an increased risk of embolic events without the atrial arrhythmia, so it's just an added risk if they stay in it long term without any proper anticoagulation.
I really think that's a key point here. One of the things that we've known is that anyone who has atrial flutter or atrial fibrillation has a higher risk of thromboembolism, stroke, and the like than a person who doesn't have these arrhythmias. But matching everything else, a patient with congenital heart disease has an even higher risk when they have these arrhythmias than a person without. And so it's really important to get these patients to be on an anticoagulant that works for them and that they're compliant with and that they'll be able to take. Stroke would be a tragedy in many of these that's avoidable. So I think we're going to talk now about, in the last 10 minutes or so, we're going to talk about some of the really potentially exciting and potentially even game-changing things that may be coming to our field in the future. So Dr. Lim, you want to start?
Sure. So in the realm of pacing, there are some developments really over the last 3 to 5 years that at least calls our attention to, because it may affect how our congenital patients are receiving their pacing technology. Next slide, please. The first one is these percutaneous epicardial pacemakers. So there were 3 studies that came out from 2015 and 2018, 3 different groups that looked at minimally invasive or percutaneously placed epicardial pacemakers. That's right, you're not calling up your cardiovascular surgeon to make an incision, whether it be minimal thoracotomy or a subxiphoid approach. These are ones that are placed percutaneously as we get epicardial access, as we traditionally do for the Lariat procedure or for VT ablations, and then sliding in various forms of pacing systems. This was the one from 2015, I think it was the Boston model. There was another model out of Mayo Clinic, which is on the next one, the next click, and then I believe there's one that came out of Washington, D.C. as well. And so these various types of approaches may allow for us to have epicardial pacing without having the surgical approach to it. The challenges end up being in patients who may have adhesions from prior surgeries. And so there have been some papers out of, I think, UPenn that talked about trying to use a catheter to try to dissect out some of the adhesions. And later in speaking with some of the team, they kind of retracted some of that approach because it can be a little bit too traumatic. But perhaps this is a means of getting epicardial pacing in some of our patients where we have limited transvenous access or the potential clot risk because of the Fontan circulation. Another thing that's out there already in Europe is called the WISE-CRT, or the wireless stimulation endocardially for cardiac resynchronization therapy. It's been around for 10 years, and it's already in patients who have a pre-existing pacemaker. They get deploying of a subcutaneous chargeable battery, and then it emits the transducer through ultrasound to this small little bullet that's embedded into the left ventricle or the systemic ventricle, and then it will actually endothelialize. It will cover up to reduce the likelihood of stroke, and then where it's deployed, because it's placed retro-aortic, they put a catheter up around the aorta through the aortic valve to find a location that will connect to the RV impulse, and then you will have an endocardial, usually a lower threshold to capture the heart. So in our patients, on the next slide, is this something that could be available for our Fontan patients, especially because epicardial leads traditionally get higher thresholds, especially on those ventricular leads. The bipolars don't always have a good home. Sometimes you need a unipolar screw in, and even those over time, the thresholds tend to increase. So if we could bite into endocardial tissue, might that give us better access for our patients? We'd either have to find out a mechanism for patients without a pacing system for it to automatically pace, or in patients who already have an epicardial system, maybe we could decrease some of the output on the ventricular output and just coordinate that impulse with an endocardial placed bullet. But perhaps this is an avenue for our Fontans. It's just coming and being FDA tested in the United States, but I would venture to guess in the next 5 to 10 years that this might be something available, particularly for the patients who have multiple epicardial lead fractures, and the surgeon tells you, it's all scar outside the heart. I have nowhere to put a lead that's going to get you a reasonable capture threshold. And then lastly, something that's exciting for my alma mater over at Rice University is, from a few years ago, a batteryless microwave charge pacing system where they can actually deploy these tiny little, smaller than the tip of your pinky, smaller than a dime shown here, basically pacemakers, and they can be coordinated depending on how many you deploy to get AV synchrony, to get biventricular or multi-site pacing. And the thought is that they would be leadless, so you don't get the wear and tear of each lead and the risk of endocarditis that needs a lead extraction. And it's rechargeable, so you don't have to say, gosh, I need to deploy another one 8, 10, 12, 15 years from now, and just maintain that power source of the microwave powered device that gets recharged. So that may be something that comes around the corner, depending. This one's still probably a little further away than the YCRT model, but might be something that could be placed at the time of a congenital heart surgery outside the heart as well as a temporary pacing wire.
Thank you for that. The other pacing approaches that I think will become more and more prevalent in our patients. The historical forms of pacing in a person without congenital heart disease usually involved a ventricular lead. Once we started doing them endocardially, they went into the right ventricular apex, and that form of pacing was not ideal in the long term, or sometimes in the short term for some patients. About 10, 12 years ago, the concept of putting a pacemaker lead directly into the conduction system, the wiring system made of specialized muscle fibers that we're all born with, came to really the forefront, and it's been really becoming very prevalent in some centers. That involves placing a pacemaker wire directly into the His bundle. And in a patient with a structurally normal, non-congenital heart, it's actually fairly straightforward in many of these patients to accomplish this. And we think it achieves better outcomes. We think that the chances of heart failure in the future will be less. But in this case, my partner placed one of these leads in a patient with DTGA and an atrial switch who had heart failure, a very markedly reduced systemic ejection fraction, and he needed a defibrillator for secondary prevention. So here what you can see is the patient had gotten an atrial lead going through an SVC and through an SVC baffle into the left atrium, into the left atrial appendage. He got a defibrillator lead in the left ventricle, and then this is a lead that's going into the His bundle, and this is what it looks like as it's going in. Now the tools for putting this in are not perfect for this use case, but it can be accomplished. And in this case, the end result, what we're looking for is to try to narrow the QRS. The QRS complex comes after each of these pacing spikes, and how wide that is reflects how long it takes for the wave of activation from a heartbeat to spread through the entirety of the heart muscle. When it's very slow, then you get a heartbeat where some of the heart muscle squeezes, and then much later the rest of the heart muscle squeezes, and it's not very effective at moving blood. But here I think we've got an EKG that looks fantastic, and this patient's systemic RV ejection fraction improved to 40%, and the patient did well. I'm going to talk now about something else that I've done, which is something that is being explored and published in certainly the pediatric EP world, and I think is going to become more and more prevalent, hopefully. So we've known for decades that if you have a patient with LV dysfunction and you add in left bundle branch block, meaning they have delayed activation of the left ventricle, of the lateral part of the left ventricle, and they have heart failure from the left ventricle side, that we can give those patients something called cardiac resynchronization therapy by adding a pacemaker lead to that side of the heart. And by forcing the heart not to squeeze like this, but more simultaneously through pacing, we can improve the function of that ventricle and improve the patient's life expectancy, heart failure symptoms, and the strength of the left ventricle. But it has really not been tested yet, that the idea that maybe if a patient with RV dysfunction who has a right bundle branch block and has right ventricular heart failure symptoms, I'm describing many of our tetralogy of Fallot patients, the atrial switched detransposition of the great arteries patients. Many of these patients have these if we perform something similar or analogous with cardiac resynchronization therapy involving something in the septum and something on the free wall of the right ventricle. Can we improve their heart function? And so this is an example of a case. Patient had tetralogy of Fallot, very severely enlarged and dysfunctional right ventricle, really a lot of heart failure symptoms and hospitalizations, had a pre-existing biventricular implantable cardioverter defibrillator. I wound up revising this by adding a His bundle lead. I put a right ventricular free wall lead placed where mapping showed the delayed activation of the right ventricle was. And what we achieved was the patient's EKG at baseline without any pacing was actually very long, very wide, reflecting a very delayed time to have the activation spread throughout the right ventricle. With the original biventricular pacing system, which is really better designed and the leads were better placed to help a failing left ventricle, when in this patient it was a failing right ventricle, the EKG didn't really look much better. But with what we did, we were able to narrow the QRS quite a bit, down to 150 milliseconds. And the difference on echocardiography on the left is the patient's intrinsic, very wide right bundle branch block, and you can see the right ventricle is fairly dyskinetic, meaning some of the heart muscle is squeezing when the other is kind of at a different phase of its activation. When we pace with this type of resynchronization, I think you can see that the muscle of the right ventricle is much more synchronous, and this was noticeable immediately. And the patient actually did well and has not been in the hospital and has felt better. And the last thing we'll talk about is leadless pacing. This is a new, not that new of a technology, but it's an approach to implant a pacemaker lead directly into the ventricles without any leads and without remote power sources, but actually a self-contained power source. Now, this is commercially available. We've been implanting these for years in general in patients without congenital heart disease. But the newer forms of these devices that will be coming out in the market, as well as some of the ones that we already have, may have a role to play in some of our patients, especially those who maybe have difficulties in placing leads due to baffle occlusions and things like that. So with that, I think I'm going to end the presentation.
And we have actually a couple questions that I think we can probably cover in the last minute and a half because they're pretty quick. So the first one is, cardiologists usually disregard PACs and PVCs. Patients that have multiple PACs, like every third or fourth beat in periods of Hegemony, that are already on beta blockers can develop heart failure due to these extra beats. I think it's a question, can they develop heart failure due to these extra beats? I don't know. Dr. Fuentes, you want to cover that first?
I'm not sure that PACs themselves could lead to heart failure. I would imagine PVCs, yes, because of the data that we already have in patients with structurally normal heart. Though certainly I would imagine that we would keep a closer monitor on them because they have such an exclusive hemodynamic significance to atrioventricular discordance and such. And so, that's what I would imagine.
Yeah. And then the second question, also a relatively straightforward question in terms of answering it. At what point would you consider anticoagulation atrial type arrhythmias or SVT in patients with septal defects?
Well, I would consider it really in those patients the same as patients who didn't have septal defects. If they're having an atrial flutter or atrial fibrillation, in a patient with an ASD or VSD, I would be using the tools that we use, like the CHADS VAS score, to try to guide us. I think the ASD introduces some possible mechanisms for thromboembolism that are independent of the atrial arrhythmias, really. But I think the indication for anticoagulation would be based on the CHADS VAS score.
Great. Okay. All right. Well, this has been a fantastic session. As always, with all of our other sessions, please continue the conversation online. I know Dr. Lamb is on social media. I believe so is Sean. Dr. Upu, I don't think I have your handle. I know Dr. Fuentes and myself are on social media as well. So continue the conversation. Send us your questions, and we'll keep the conversation going. Thanks for joining us. We'll take a break till 12:45, and then we'll be back for our next session.
Thank you, everyone.
Thank you.
Thank you.
which is good because I kind of needed that to kind of understand who she is, know who she is, and she's a very, very lovely person who rolls with the punches too.
Okay, great. Hey guys, how are you?
Which, am I looking at number 2?
There we go. All right.
When they talk.
So we're going to get rolling here in just a minute. Just wave your hand if you can hear me.
I don't think Lena can.
Sorry, Michael. Hey guys, sorry my microphone was off. Apologies. Wave your hand if you can hear me. Excellent. Okay, so we're going to get rolling here in just a minute. The rest of you guys sort of discuss the really important topics that you guys have sent online. Okay? And don't forget to unmute yourself as we're going along, just like I forgot to turn on my microphone. So, all right, so we're gonna get started. I'm gonna go ahead and introduce everybody, and then we'll get the ball going. Okay? They're going to give us a countdown and get rolling.
So you good?
I'm good.
All right, let me close the door. Chris, you're going to look into camera 1. Chris will give you a countdown. 5, 4, 3, 2, 1.
Oh yeah, turn off your phones.
Snows, I would have gotten you some too.
Hi, and welcome back. This is by far going to be one of our most popular sessions for this year's Adult Congenital Heart Symposium. Here we're going to be talking about mental health and adult congenital heart disease. With me in the studio is again Annie Olchak, who joined us earlier this week. She's also a lifelong expert on adult congenital heart disease with a history of single ventricle physiology. Hi, Annie.
Hi, thank you for having me again.
Thanks for joining us again. And then, of course, coming in live from multiple different places across the country is again Dr. Leif Al-Shawabki from San Diego. And new for us is Maria. Hi, and welcome back. This is by far going to be one of our most popular sessions for this year's Adult Congenital Heart Symposium. Here we're going to be talking about mental health. Excuse us for a second while we fix our technical issues with the audio. She's also a lifelong expert on adult congenital heart disease with it. All right, we're back. Okay, and then also is our great friend, Dr. Ari Cedars, who's at Hopkins and runs the program in adult congenital heart disease there. Also, one of our lifelong friends is Lena Morsch, one of the co-founders of the Zipper Sisters organization. And finally, I was just about to introduce you, Maria, when I got interrupted by myself. Maria, welcome, also from San Diego. Hello. So let's get the ball rolling here. So one of the first topics that we really wanted to talk about is how to navigate the very complicated situation that social media has become in this scenario where social media is also one of the best ways for our adult congenital heart patients and family members to engage with other people like them for sometimes the first time in their lives. So Annie, since you're here with us, why don't you tell us a little bit about how you interact with social media and how you sort of get through some of the complexities of being on social media these days?
Thank you. So I think what's interesting about social media is it can be one of our best forms of resources, but also one of the worst and scariest forms, especially depending on your congenital heart defect. Some congenital heart defects are very well known. You know, they're the popular ones that we have out there. For instance, my own, anything to do with Fontan related, liver related, HLHS related, tritology of Fallot, and etc. Whereas when you have other lesser known CHDs, they may not be able to find as much information. They may not be able to locate other peers that are in their boat. And so I think what's great is we have things like the ACHA, the Adult Congenital Heart Association. We have Mended Little Hearts and a few others out there. And Facebook, as you said, with Zipper Sisters for females with congenital heart defects. And by those avenues, we're able to sort of show them the way, a journey, and how to find the right doctors, the right resources, and then speak with other patients who will tell about their own experiences versus, you know, just making it one big blanket statement. So.
Wonderful. So Lena, why don't you help us out here and tell us some of the issues that you've run into recently on social media.
I just hear Annie talking. I don't know if anybody else is like that.
Journey and how to find the right doctors, the right
but I guess we'll try to talk over
and speak with other patients who tell about their own experience.
Some of the biggest issues that we have within Zipper Sisters and peer support, I think is.
I'm sorry, why don't we take a 2-minute break and we can try to fix our issues.
Tell some of the issues that you
and we'll be right back. We'll be right back in 2 minutes.
Stand by. 5, 4, 3.
Okay, and we're back. So, Lena, we were just going to ask you what your thoughts are as far as how to navigate the complicated situation that social media has become, especially because some of our most important friendships and relationships now in congenital heart disease come from social media.
That's right. I hear feedback. I think peer support is the strongest the strongest avenue you can take when you're suffering from post-traumatic stress or looking for support. I think that comes from the lack of resources, unfortunately, that we still have. It's the elephant in the room. There's a lot of administrations that still don't believe that we need money for mental health. So the advocates still have to work really hard for that.
That's good. Okay.
And also finding a qualified mental health care provider that specializes in a lifelong chronic illness, which I think that's different than most situations. Especially dealing with post-traumatic stress. And that doesn't come just from a medical emergency, it comes from yearly doctor's appointments. Whether you're a strong advocate and you think you're okay, every time that yearly appointment rolls around, that really raises a lot of red flags for patients. So luckily, we have programs such as the ACHA Peer Mentor Program. We have Zipper Sisters, hoping one day to get Zipper Brothers going. But finding somebody that's been through similar situations than you have has received the best feedback. And my 10 years of advocacy, that's patients reach out when they meet somebody that's like them, and they think that's just it's a godsend. It gives them the strength to find a new cardiologist, get into the right care, go ahead with that pulmonary valve replacement or whatever is needed. So we're very fortunate to have the group. It's kind of limited. We only get half of them in there. But it's very, very rewarding. So I always, when I talk to clinicians, I emphasize the importance of peer support.
Well, I think you covered a lot of ground there, Alina. So why don't we take a few of those pieces and separate them out, because I think that each of them is really important to talk about. So Maria, when we talk about the trauma that Alina just talked about, especially that kind of scary episode of coming in to see your adult congenital heart provider once a year and watching the days progress as you're getting closer and closer to that visit. Talk to us about how you address that with your patients and what we can do to make that a little bit easier.
I think the key is having open communication and really listening to them. I tend to go in before the physician sees the patient or at the same time and kind of evaluate where they're at before introducing topics, and just try to carry on a conversation, make them feel comfortable, make them feel at ease so they can trust where they're at. Try to just hear where they're coming from, what their concerns are, and then after the visit, again, talk with them. And I kind of roll with where the patient directs me, whether it be watching their affect, if they feel closed off for suggestions, or if they feel really open, and then engage my plan from there. I inevitably turn them to the ACHA for sure. I pull up the website, I show them what's available to them. That's a big part of it. And another part is also, as we get to know them more, is try to introduce them to another patient that I'm familiar with that I feel like they might connect with.
Great. Dr. Al-Shawabki, Dr. Cedars, any thoughts about this so far?
Yeah, I second what Maria said. She really ran with the what we call an ambassadorship program that we have here. There's a group of patients that Maria has identified who she thinks have specific skills in supporting others. And it's kind of fascinating to see how patients evolve and develop long-lasting friendships because of this program. But also, we have to be realistic sometimes in recognizing that generally our adults with congenital heart disease are less likely to seek mental health, professional mental health assistance. So we try to engage them from that perspective and encourage them to seek specific providers. And as Lena indicated indirectly, it takes several providers sometimes to find the right fit. And then once you click with that person, hopefully that's when the healing and the recovery begins. The best time is when you're not urgently needing cardiac care. You're not anticipating surgery, you're not anticipating a major procedure. Obviously, you need more intensive mental health support during these periods. But the key is to start early when you're feeling good, when you're not in absolute need of these services.
I think the idea of a peer support group is pretty remarkable. I should try and develop the same thing at Johns Hopkins where I'm working, because we don't have that right now. But that's, I think, would be a very useful adjunct to typical psychological therapy for patients that come in. I mean, and then I think, Laith, you touched on something that that I believe is also important, which is that it's not always easy to find a mental health professional, and it may be that there are multiple touches with the medical system before mood disorders or depression or anxiety are identified. And so that may be a role that we as providers can provide for our congenital heart disease patients, knowing that they may experience PTSD, knowing that as a result of that they may be prone to depression, and knowing that depression, greater than almost any other cardiac factor, plays a role in a patient's quality of life. And failure to address that is probably omitting a very important part of their overall care.
So Maria, I know you've had a lot of experience with also helping our patients through trauma and their past trauma, and helping them walk through it. Talk to us about some of your strategies for helping your patients.
Sometimes helping them to even articulate what that might be. Some are very connected and can say, okay, I remember I can't go to the dentist because I remember having these tubes in my throat or in my nose, and so anytime I go to the dentist, that's where her stress is. So then we just talk about strategies for her. For instance, I tried to find a dental institution that would give her anesthesia to help alleviate that. But mostly being open to listening to what their concerns are and why they might not pursue the help they need. Sometimes just trying to get them to identify what it is first. So the self-awareness component, helping them with social support, family support, and teaching some self-soothing techniques, breathing, what other activities do they have? Do they exercise? Maybe some art. I saw a patient a few weeks ago, and she's involved in all these different types of extracurricular activities and was able to connect me to some of those, so now I can relay them to my patients, local services. So it's a collaborative experience where I can share what I think may be helpful, but sometimes patients as well have some idea what they might need, and then to kind of take it from there. Distraction, physical activity, camaraderie with other patients.
Right, thanks. And then, so Annie, I know we were talking about this the other night when we were actually talking about your diagnoses with serositis and fluid retention and things like that, that all of us, or all of our patients at some point, have to undergo getting a difficult or very bad diagnosis. In some situations, of course, some of our patients have gone through the last 15 years of their lives not realizing that they have congenital heart disease, and coming back into care represents a re-diagnosis or a new diagnosis. Talk to us about how you managed your feelings or got through some of those very hard times when you got some of these very challenging diagnoses.
Yes, so it wasn't easy, and I constantly emphasize that. It's not a simple process. It's not an easy process, and it's one where you do, as difficult as it is, you do need to speak up and advocate with your medical team. And I don't just say one doctor, I say a team, because they all have to work together to help you in your many different issues, systems, diagnoses, and procedures that you're going to be going through. For me, I think the part that was really tough was the pain, the physical pain behind it. Sorry. Wondering how long it was going to last, even with all the help that they did with, trying to numb you physically before you're going in, trying to get you to calm down. When you're going through it and they're sucking up your intestine or accidentally sucking up your bladder, and there's nothing that's going to numb that, and it's days of pain afterwards with your digestive system or anything else. You say to yourself, how can I keep going through this over and over again? And working and finding a group, I was very fortunate in finding such a wonderful group like the Zipper Sisters, who everyone has gone through something similar. I was able to, it took years before my PCP, who only works with chronic conditions, was able to form a chronic conditions group, a mental health group, that they decided they were going to have some of their really mentally not ill, but those who still needed to process, because when you're in chronic care of any form, it's lifelong. This isn't something where tomorrow I'm never going to need a paracentesis again. It's going to happen whether I want to believe it or not. So how do I physically and mentally prepare for something that even to this day still gets me saddened and scared? But with working with that team and having very intense therapy, and I don't know if there are other programs out there like that, and I really wish there would be, because twice a week, one was with just the doctor and one was with all sorts of patients with all different type of chronic conditions and what they've gone through, and working on what is the pain itself that we fear, what is the situation that we fear, how do we cope through it, how do we process it, even our past working with our families, working with things that may have happened and what causes us to react or deal with the situation in a certain way, because everyone has different backgrounds, so everyone has a different way of dealing with it, and how to be proactive with your medical team as well as yourself, and being honest with yourself to say, listen, this terrifies me. I really need something to calm me down, because what you're about to do when I hate needles is going to dig through, and now my fear is going to triple fold. So can you help me? And sure enough, a lot of people with the anxiety behind it get afraid to say it, but if we can speak more and explain more of what goes on, it in the end helps not only us, but it helps our medical team to understand that it's not just one person, it's going to be multiple people, and they're already prepared for what this patient may be saying now and in the future. And so also teaching us how to cope during that current time is key too. Finding a space within yourself on how to sort of relax, and it's not always easy, trust me. I don't think I'll ever truly be able to fully relax on certain things, but at least to get my own self in a place where I'm ready for whatever pain or procedure is going to occur is ideal. And so so that's how I've managed and continue to try to manage.
Yeah. Thank you so much for sharing what's obviously very difficult to share, and has been a very difficult part of your life that's become recurrent. I think there are a couple of things that I want to pull from this to stimulate a little bit more discussion with the rest of our group here. The first one is that it's expected. Yeah. That with our patients, all of you have had these experiences in your lives, that it's no surprise. And I would almost argue, and I'm sure Dr. Al-Shawabki and Dr. Cedars would agree, that it's almost normal for an adult congenital heart patient to actually experience medical trauma, that every needle, every paracentesis, every thoracentesis, everything that reminds you, dental procedures, everything that reminds you of those previous experiences brings back these episodes of pain and the trauma. So I think normalizing that for our patients and making it understood that it is not wrong to feel these things, I think, is a critical part. I think the other thing that I'm hearing a lot about is how the peer support is so critical, and it's almost that we have to be very intentional about getting this to happen. That it doesn't happen accidentally, that you can't just fall into it. Obviously on one side, we physicians and healthcare providers have to help to provide an avenue by which that happens. But I think at the same time also that you as patients need to find the right peer group for you, because it's not a one-size-fits-all situation. And then finally, I think one of the things that really is important from what you told us, Annie, is that we have to be intentional about working with professionals from the standpoint that you mentioned, a team that helped you to work through the trauma, that in part it was peer supported, but then it was also supported by a mental health professional. And I think that is crucial for finding a way forward. And that's just not necessarily something that we cardiologists are necessarily the best at. Team, any thoughts about that, about how to help our patients with those things?
Maybe a circle back to Annie. Hi, Annie. How are you?
Good, thank you.
I haven't seen you in a while. It's kind of interesting. You joined this group for chronic conditions, and obviously you're very engaged with the ACHA and the adult congenital community. What points of wisdom you would give us about that shared experience above and beyond congenital heart disease? Do you think expanding your horizons to chronic conditions have offered you above and beyond what we in the congenital heart disease community focus on?
I think so. I think realizing that there are so many other groups of people that suffer through, if not something similar, then at least the pain behind it, the mental anxiety behind it. It sort of helps the medical community capture and realize that we're all going through something that doctors may not always recognize. And just because I have a congenital heart condition versus someone who has, maybe a cancer diagnosis or leukemia or anything like that, we're all going to be going through procedures because fluid buildup, needing operations, needing tubes to drain and help, and that constant peer support and medical, you being able to say to a patient, well, you know what, there's a wonderful group here that we work with, or groups, or a program that we have, or programs from other hospitals that work together simultaneously to help patients. It may not be in your own state, but if they're able to virtually, and that's beautiful that we have this virtual aspect today, that we can virtually gather all together, and even the doctors talking amongst themselves to understand, well, patient A, B, and C didn't have this issue, but patient D through Z did. So what were some of the ways you managed to help them go through that process so that, and it's never going to be painless, it's never going to be pain-free, and it's never going to be easy, but at least if it helps a patient understand that they're not the only ones and they're not alone, that's the key point.
So maybe reframing that and asking a different question to that larger group. Maybe Dr. Cedars and Dr. Lynn can weigh in as well. And obviously Maria. We as providers go in with a plan. We've already looked at the echo, the CAT scan, MRI, exercise test, and so forth. So we have a very good idea of what kind of counseling and advice we need to give the patient, whether that's let's continue active surveillance once a year, or you know what, I'm going to need to see you more frequently, or let's consider doing something. From a patient perspective, what I've noticed, and it's helpful to have somebody who's acutely aware of nonverbal cues, like our senior nurse Maria. She's always with us in the room. She's noticed that a lot of patients just, it stops. They stop processing new information as soon as you give them quote unquote bad news or not the type of news that they're expecting. And it's hard for them to come back with questions or follow-up. And it's often after the provider leaves the room and she spends some time with them that she comes out and gives me more insight into why, what they're thinking and what their needs are, and I would have to come back in the room. Can you give us advice, the group, from both provider, nursing, and patient perspective about this important issue?
I think that's a really important issue. I think contribute to anxiety if somebody, their brain has shut down because they've received bad news, and then everything that follows, some of that information may actually alleviate anxiety, but they're not in a position to be able to absorb it at that time. And I actually don't really know, first, a systematic way of screening for identifying that, short of having a Maria to sit in the room with me, which I'm not fortunate enough to have. And what I have been doing up until now is making certain that I'm accessible as possible, so that once patients have had an opportunity to return home, discuss things with their families, process some of the information, it's easy to get back in touch with me to talk. And then making certain that there's close follow-up, and at each follow-up visit, I screen patients for symptoms of anxiety or depression with a simple kind of questionnaire that patients complete, people complete when they come in to see me. And if I identify them as having any of those symptoms, then I connect them with a psychologist, because I'm really not trained to help out with some of the coping mechanisms that can be taught to help confront some of these challenges that may come along with a new diagnosis, and knowing that you need a procedure that may be potentially painful, and the PTSD that might elicit in the individual patient.
I agree. You brought up a great point, and I think access is key. That once they maybe hear that something's going on, that they have someone to reach out to. There's the MyChart tools that people can send messages, but sometimes gauging that they need more time to process, or they might want to meet several times to just talk about things. I might just set up multiple nurse visits, or make a note to myself, okay, I'm going to call this patient every week and check in with them, and then kind of reassess as we go, and then determine based on how receptive they are, then knowing sort of what the next steps are. It for sure is helpful when there is no urgency to needing a procedure or needing something more in depth. I think it's just spending time and really getting to know your patients well, so then building that trust, building that relationship. And most of the time they'll be very forthcoming what their needs are, and then you can kind of customize based on that.
So, Lena, talk to us about how you guys use Zipper Sisters intentionally to sort of address some of these issues that we've talked about today. And tell us some of the resources you point people to.
Gosh, so many. It's such a vast subject. But first and foremost, we always try to direct our patients to the Adult Congenital Heart Association Peer Mentor Program, because the peer mentors are not only peers, but they have been specially trained through a pretty vigorous selection process. So they kind of know how to handle a crisis with a little bit of professional expertise inside that. But within our group, we have, as I said before, so many issues. There are a lot of sisters that we know that need mental health care, but they don't have insurance. or they live in a rural area, and it takes a lot of money just to drive to a big city for a yearly appointment. So it's really hard to navigate that. As the longer I've been doing Zipper Sisters, Annie and I, we've been lucky to have providers reach out to us and groups that let us know of studies and resources. And so my thing is to rally the troops, kind of be a pain in the butt, and demand like a patient family alliance at the hospitals or some sort of support group. Currently, I crashed UCLA's support group, and I think that's ideal. They're very fortunate to have a social worker that's also, he has CHD and a transplant patient. His name's David Highfield, and he has a once-a-month support group via Zoom now that it's that we have COVID. And it is amazing because not only does he have the professional expertise and he works in a hospital setting, but he went through transplant about 2 years ago. That would be kind of my idea thing, is to have each Zipper sister or Zipper brother to go in and see how they can get something like that formed. I'm kind of going off track here, but we see more needs than things that we can suggest, and that's the sad part of it. That's why there's such a need for Zipper Sisters and why we're so popular, is because there's very limited resources to reach out to unless you have the different type of heart disease. So I find myself frustrated all the time, and I'm learning and asking questions. I was very fortunate personally to have not only an awesome ACHD cardiologist, but he also had a dual degree in psychology, which I probably really needed because I was a hot mess. So he had to deal with a lot. Moving on to Boston for my care, I don't know how my new cardiologist is going to have big shoes to fill, but like Maria had said earlier, it's to getting to know each patient individually, kind of their personality traits. Do they want to know? Do they not want to know? And listen to the patients. The patients know what works and what doesn't work. Zipper Sisters is extremely popular because of word of mouth. That's kind of where we kind of took off, and listen to the patients because they know what works better than anybody else.
Yes.
Mm-hmm.
So there were a couple of questions and comments that came online for us. So the first one was, how do we incorporate the use of chaplains, both here as well as elsewhere? So I have to be honest, I don't know that we intentionally use our chaplaincy here within Houston Methodist, which is unfortunate because we're Houston Methodist and chaplaincy is a very important initiative here at our institution. So I think that that's something I'll have to take back to our program. We'll have to think a little bit more intentionally. Laith or Ari, do you guys use or Maria, do you guys use your chaplaincies very often, and how do you do it?
I have to say I haven't used it in the outpatient environment. I know that they do have it in the inpatient environment. I was checking in with one of my patients the other day, and they came in to do last rites, and it meant a lot to her to be able to have the chaplain available. Social work usually would be the one to help arrange that, and we're fortunate because we're in the process of hiring a social work, so I'm looking forward to that support and added resource, and hopefully they can help with some therapy as well for this patient population.
I have to agree with Maria. I think that it's a real underutilized resource. I think probably every hospital employs a chaplain for the purposes that Maria was talking about, but I do think it's something that could really add a lot to the outpatient experience. I have not actually even thought previously about employing the chaplaincy in that way, but I think it would be a great resource. And now I'm thinking about it. I'm glad for that question because now it gives me an idea of something I can do to potentially make the program better.
And Lena or Annie, have you guys experienced or known anybody who has experienced a really good outcome or a good solution with using their chaplain or chaplaincy system?
I used it as inpatient when they were trying to figure out my congestive heart failure and my FALD and everything that was going on with it. Like Dr. Cedars said, I don't know of any outpatient groups that use the chaplains, but I know for inpatient it was wonderful because they would ask you what religion are you, and they my hospital that I was at for the most part was able to have a various amount, and I said being Roman Catholic, they did have a Christian chaplain on, and I was open to that and able to speak with that person about my fears, the pain I was going through, but also because so much was up in the air and unknown with what was going on with me back when I was in my late 20s. FALD wasn't really known back then. CHF, they couldn't believe that I had something like that since I was constantly exercising and training for things. And that person was able to talk to me about death. It's not so much the being dead part that frightens me. It's the getting to that process of dying, everything that's going to go on in the background, because a lot of it is a lot of pain or unconsciousness and being aware and unaware of different things and trying to mentally prepare for that. And so they did a great job. We talked, we prayed together. They understood my fears. They said, if there's anything you'd like me to relay to your doctors that you don't feel comfortable saying or asking. And they were wonderful. I really used them a lot. They came up every day. They would call me, would you like to speak with someone today? They gave me a Bible, it was great. And I wish more doctors and programs had that availability with those kind of programs.
And then the second one was a comment specifically about saying that we need mental health professionals in ACHD who are actually trained in trauma, and I think we'd all agree on that at this point.
Absolutely.
Yes.
So the other topic that I think our group here wanted to talk about a little bit is how to navigate the information versus disinformation that oftentimes we run into on social media, especially about congenital heart disease and what that management should look like. Because today, unfortunately, on social media, everybody's a medical expert and everybody has a sense of what should and shouldn't be done, whereas this is a very complex area. So, Lena, let's start with you. What are your thoughts?
Oh my gosh, I'll have to tone it down. We all discussed this prior. It's been a rough 2 years, and we've learned a lot. It's extremely frustrating. I think with COVID, a lot of people know the frustration of what it's like to talk about CHD in the world of acquired heart disease. Because you tell them one thing and then they just go back to kind of what they know or what they believe. And Annie and I have always preached this, that there are two different types of heart disease, and we need to keep saying that over and over and over, because people assume because one demographic is taken care of that we are. And so within Zipper Sisters, every crisis that we have, it's not just mental health, it's lack of treatment, or you name it. We're still the pioneers of CHD. We're all the front line. It's frustrating, but we need to keep hammering away that there are two different types of heart disease, and we are the underdog of the heart disease, and our doctors need more support. Patients need to know the standards of care, whether you have a simple, moderate, complex CHD, what accreditation is. There's just so many things at the beginning, the simplistic things that patients don't know, and it's ever changing. And we find ourselves always having to read and to try to catch up on it too. And I also want to say it's really hard on social media, because you cardiologists and researchers like to talk to each other. which is fine. But when there's, say, research coming out about tetralogy of flow or something, I wish there was a way that a researcher could relate that to patients. Because every time I click on something, you can see the abstract, but you can't, you don't have access to it. So, patients do want to learn, so we need to make that more accessible. And, we need to carry that banner. 2 different types of heart, well, more than 2, but, different types of heart disease. Because until we nail that through people's heads, I don't think we're not going to move any faster than we have been. Maybe Annie can piggyback on that because we had this discussion late last night.
You can see me nodding my head because it is so true. I mean, you see the banners and the posters when it comes to acquired heart disease, and when you're being told that 1 in 100 babies are born with congenital heart defects, disease, and there's nothing, there are no banners, there are no posters, there's nothing on the highway saying, help us, or here's a hospital that can help you, then how do you sort of preach from the top to say, we need it too? We need the fundraising, we need the research, we need the doctors to be able to want to go and learn more about congenital heart disease. Or, not only just the congenital heart disease doctors learning more about us as adults, but also the complexities of all our other organs and what's going to happen to those with our operations, the life-saving operations we've received, or the organs that are already, quote unquote, repaired. And it's so difficult. And when you have, as Lena was saying, people shouting about other parts and not letting us read the research, or making it understandable, so that if I'm going to read something about what's going to happen with liver disease, I need to make sure I have 2 different dictionaries. I have the Webster's dictionaries and I've got a medical dictionary, so I know, and I'm highlighting and basically doing an entire research of the research papers so I understand what I'm reading. But I'm also not giving out false information to someone who may be asking me, what did you think of this paper? Or can you give me some resources of anything you may have understood or read to help me bring it back to my doctors, to help me maybe talk about it to my teenager. Parents reach out to us all the time asking for help on different avenues as well. So like Lena said, it's understanding that there's more than just one heart disease out there. There are many, and the congenital one, it's just, I don't know, maybe it's not sexy. Maybe, and that's why. But
I don't know. I think you bring up excellent points, but I'm going to take it back to you and Lena and tell you, you too are the forefront. You're the pioneers in congenital heart disease, and you're heading a massive endeavor along with the ACHA and platforms like Methodist, DeBakey, Dr. Lynn's group, for giving people this platform to advocate for congenital heart disease care and lifelong care. But going back to social media, I have to hold the bull by its horns. I think we do, as providers and caregivers for our patients, I think we have a responsibility for being intentional in addressing these issues with the patient during the visit.
Yes.
We have to live the moment, whether that's COVID-19, vaccination, and all these issues. That should be a standard question in the room about these problems, and understanding and hearing out the patient and being as objective as possible. We do have data. The Congenital Heart Disease Committee came together and produced high-quality evidence specifically for COVID-19 effects in patients with congenital heart disease. Patients may not be aware of it because the social media is littered with general heart disease, as you said, not specifically congenital heart disease, but we do have data. And I promise you, every ACHD provider is fully aware of this data, because in all likelihood, they or their center has participated in that type of pooling massive effort that took place last year at producing this evidence.
I think that actually one important missing piece is making certain that you have good rapport with your patients, because people listen to those who they trust. And this is the same on social media as it is outside of social media. And so if you have a good rapport with your patients, I think the most important thing we can tell people is that you can get useful information online, but there's also lots of unreliable information online. And I'm always here and available if you have any questions at all. If you'd like to discuss something that you read that is of interest to you, that's of concern to you, if you'd like my opinion on that. I think if you've got good rapport with your patients, and if then we can't control the media. We can't control what's going to be published online. We can't control what people are going to be reading. But if you have a good rapport with your patients, then and they trust you to come back and speak with you about whatever they may have read, then I think that's kind of the missing piece. And I think that's a good way of sorting through what's believable from what's not believable for an individual like Lena or Anna, who may be reading things online and not really know what's a trustworthy and reliable resource versus what's not. But the second point that Lena brought up is also important, and it's a big gap in the ACHD community, which is a consistently or reliably updated source for new information on congenital heart disease. There isn't like some kind of a summary report or a summarization of recent data that comes out on a quarterly basis that's specifically related to congenital heart disease. And I can understand how these things are in the media, in the New York Times or in the Wall Street Journal for acquired heart disease, but are not present for congenital heart disease. And I can certainly understand why that's frustrating for you. And I do think that that's something that as a community of providers and researchers, we should get together and try and rectify. But again, even that would be just one more voice in the social media cacophony. And so I still think at the end of the day, it's going to be important that there's a good relationship between patients and their individual provider.
That's very true. Sometimes though we have to kind of reel in patients that think that their general cardiologist is just fine. They're small town local cardiologists. So we have to back up. In an ideal world, everybody would be going to an accredited center with one of the 300 plus ACHD cardiologists we have now, but. We still have a lot of work to do on that aspect, and especially with COVID. I mean, not that I want to dive too much into that, but there are patients that when their cardiologist has recommended the jab, they want to go elsewhere. so that's a lot to work with. It's ongoing. It's daily. And. We try to read up as much as we can. We take shifts because we all work, and we try to educate ourselves as leaders, as Zipper sisters. But some days it's crazy. You don't know what's going on, and that's on top of learning about the lesions, and all the topics that women have with CHD.
Yes.
Besides pregnancy, I mean you guys are doing a very good job covering that. But we're always looking, and we're always welcoming any type of education you want to throw our way because we need it. Some days we're drowning.
Yeah. I have to agree with Lena, and I have to agree with Dr. Cedars here in regards to having a good rapport with your doctor or medical team, because I do have to give a shout out to my the cardiac PAs. They are wonderful if when the doctor isn't available to be the on-call person first to help navigate the question, navigate where the patient needs to go to, who they need to reach out to, because I mean the doctors are just so busy with their day in and day out procedures and surgeries and patients that they need someone helping them, and having those social workers and having those PAs and anybody else and therapists that can be part of their team and their group, it helps the rest of us navigate not just our own hospital normalcy, but also be able to help those socially online on where to go, who to reach out to, areas that maybe they can start working and getting together for their own hospitals if theirs don't have it. And then realizing that, oh, now that we've asked this question to them and they've done their research with their own doctor, maybe there is a program they weren't aware of, and that opens a whole new positive floodgate of, guess what we have at this hospital, guess what my doctor is able to do. So yes, thank you.
Absolutely. Well, so this has been a fantastic discussion, and I think we've hit on a number of different very important topics that can't necessarily answer specifically today or have a perfect answer for, but I think really help us to take into the next direction and the future for what our field really requires. And I think one of the most important things that we've discovered, as we have in the past too, is that the patient's voice is so important to help us to really understand what our needs are from that standpoint. So I think major things that we've talked about today are mental health from the standpoint of medical trauma that is really normal in a lot of ways for our patients. And I think all of our patients out there and their family members too should understand that it's normal and there's nothing, and although it's bad, that it's not wrong to experience it, and it's okay to admit to it. That we have to be intentional about how we address that we need more help from mental health professionals who have experience in trauma. We need to bring in some more of our resources, such as the chaplaincies, as well as other people who are invested in the outcomes of our patients from the mental health standpoint. Two, I think we've all talked about today how social media has really changed the way we consume information now, and that becomes really important for how we care for our adult congenital heart patients, and that means so much more now that we have to invest in the rapport, both physician, providers, and patients, and as well as their families, in terms of ensuring that the right information gets to our patients and their loved ones about their care. So I want to thank all of you for being here today for this wonderful session. Again, I'm sure I speak for everybody that we want to continue this conversation after this session today online. If you have questions specifically for any of us, please do not hesitate to reach out to us. And of course, if you have comments or things that you want to talk about, reach out to us as well, because I think this will be a very important discussion going forward, not only here, but also on social media. Thanks, everybody. We're going to take a short break, and we'll be back in just a couple minutes for our final session.
Thank you, Huie.
Thank you.
Thank you.
Welcome to our final session here at the 2021 Houston Methodist Adult Congenital Heart Symposium. So again, as before, with me in the studio is Annie Olchak, who has a lifetime of experience with adult congenital heart disease, as our two friends who are joining us online. So first is Joe Valenti, who is one of the co-founders of Team Uncle Joe, and he is also a board-certified patient advocate. And also with us is Eliza Martin, who is a board member for the Adult Congenital Heart Association. Welcome, Joe and Eliza. So during this final session, we're really going to get back to our roots for the focus of the Adult Congenital Heart Symposium, which is, number one, patients as educators, and number two, really starting to move us into the direction of patient-centered education. So we've covered a lot of topics today. Most recently, we covered the topic of mental health, and I just want to kick us off here at this point and hear from Eliza and Joe what your thoughts are from what we can do better about mental health and adult congenital heart disease, and what direction you'd like to see the whole field go. Joe, start us off.
Yeah, I think as providers, we can really be working towards providing more of the integrated services to these patients. We know that they have specific needs and that they have all this trauma, and I think that providing more of a closed loop when they come into the clinic can really be a benefit to them. I know a lot of these patients, as Annie talked about, are going out and seeking these services and having to find them on their own, and are going out and treading this road on their own and having to figure it out. If we could bring these services into the clinic and have a more integrated services for them, it would be a huge step forward for the whole adult congenital world.
How about you, Eliza? I know you do a lot of work with ACHA.
I'll take that one step further, and I'll say that I think it's really important to start to spread the message beyond the ACHD clinics, is to start to educate. We're adults now. Thank goodness we're surviving later and later into life. Which, at 53, I think a lot of people look at myself and are just amazed. But I think because as we're growing and as we're getting older, we start to take on a lot of the other health issues and advocate for ourselves on behalf of other issues other than our CHDs. And just like everybody else, it's very important to take a holistic approach to your care. I think as patients, one, we can start to educate the doctors that we see outside of our CHD clinics and explain to them, this is my defect. This is how we have to work together with my CHD doctor, but also understand that there are certain parameters to my own mental health and to my own reactions to procedures, to the way I'm treated, the way we have conversation. And what I really need for you to do is for you to listen to me. And I think if we can start in the CHD clinics and then move it out into the emergency department, neurology, gastroenterology, obstetrics and gynecology, into those general practices, and give them an education about our mental well-being and a lot of the things that both Lena and Annie touched upon, PTSD, and all the way down to I've been stuck every day of my 1 month hospital stay in the fingers, so my fingers are numb, and that triggers something in me. I think it's important to advocate on behalf of ourselves and the larger community for better mental health recognition and listening skills.
That's great. That's some wonderful feedback. And then we talked a little bit today on some very complicated topics about arrhythmia management, and then some interesting, really cool things on the new technology that's coming out for pacemakers and defibrillators. Any thoughts about that? Starting with you, Annie, as far as where you'd like to see the field go, and how it can be more patient responsive.
I think including the patients in some of their conferences, those who have been through it, those who have had the AFib and the atrial flutters, and any other rhythm issue, or having examples. If they're not able to have patients there, then they have example of patient X, who is lifelong care, et cetera, et cetera. Now, not only are they dealing with, having their ACHD stuff, but some of that can be triggered, the flutters can be triggered because maybe all of a sudden they were over-exercising or they weren't eating right, or all these little factors that doesn't help the heart together. And so by being able to talk about the patient care, being able to talk about the patient's experience, and then where they are currently and what they see in the future for them. And granted, not everything can be listed for the future, because if that were the case, we'd all have perfect care.
That's right
now.
That's
but
right.
to an understanding of knowing that this is what they're hoping to accomplish, and this is what they're hoping and where they plan on going, and how all these new devices, all these new ways are going to help patients, so that when you have younger ones, children and babies, and their parents who are asking these questions about what's going on with the adults, they have the hope, not just us, but they also get hope for their child, who will hopefully and potentially grow up to be 42 like me, or 53 like Eliza, and etc.
So Eliza, do you have any thoughts on this?
I do. My first personal experience with an arrhythmia was this summer. And as a congenital heart patient, I know my heart has always been unusual and strange, and I really kind of took it for granted until I happened to mention it at a routine appointment. And then there was significant follow-up, and I got a Holter monitor for a very long time. But I do think it's important to, when you notice anything, to bring it up, to speak up well, and to listen to your doctor. Learn what it's about, and that it may be something or it may be nothing. I also think that brings into play this concept of mental awareness and mental stability. I think it's also important to bring it up to your doctor, and for you and your doctor to have a relationship that doesn't immediately elevate it to a position of heightened anxiety as well.
Great suggestions. Joe, anything else to add?
Yeah, I was going to say we talked about all the devices that are coming out, and I think for the patients, the biggest one that I hear is the ICDs and the inadvertent shocks. And I think that that's a huge part of that needs to be researched in the new algorithms that are coming out. And that goes to patient-centered outcomes research. And I think we're working on that with Houston Methodist, and we have a PCORI grant, and we have a multi-stakeholder collaborative that we're putting together. And the slides have been running for it today. You've probably seen them come across the screen, and we're still recruiting stakeholders in the South Central U.S. And it's a great group of people we've got put together so far. If you're interested and you're looking at being part of that group, we would love to have you. It's adult congenital heart disease patients and or parents of teenagers that have congenital heart disease. And so we're still looking for stakeholders to be part of the group. And we're going to be driving what is being researched for adult congenital heart disease. So it's a really exciting time.
That's a great plug. Thanks, Joe. And so let's go ahead and move on to our next topic, which is the advanced heart failure therapies and transplant. That was a really dynamite session with some very, very exciting discussions about how, even though it's such a complicated area, that it can be done successfully at multiple centers now. So let's start with you, Annie. Anything that you think that we need to do better about communicating what's happening in the heart failure and transplant realm for adult congenital heart disease?
I think you need the honesty that some patients, and I know they're not going to always know this answer, but are you really going to be a great recipient? Is this something that's going to set you back for several years where you don't even get to enjoy your new organs because you're dealing with the inundation of more procedures and more things because maybe as a recipient you weren't the most ideal candidate, and that can be tough to to understand. And then also, if a patient chooses afterwards, hearing through everything, talking to the multiple doctors, talking to the facility and everything that's going to happen, if they choose not to go through something like that, or what palliative care will they be given and resources to go from there. But having had many friends who have gone through transplants, and some of them through double transplants, it is the mental health behind it too. Realizing that you're not going to, after all this is said and done, run a marathon. I mean, they just want to be able to go out for a nice walk, have fun with their friends and family, have what we consider, when we see other people who aren't CHDers, a quote-unquote normal life. They want that back. They want something so that they can look forward to in the future. So I think working with the medical health providers, as well as maybe even peer supports, those who have gone through the transplants, and connecting them, or being able to read a documentary that they may have written up, a document stating how they felt and the different things, and hear the resources behind it that I sought, and this facility has it, or maybe that facility has it, to help them. So yeah,
that's great feedback. Eliza and Joe?
Transplant feels enormous because it is enormous. It is a giant. It's I guess the best way for me to put it is kind of like it's the Mac Daddy of our procedure, our world in a way. But I think what has stuck in my head from today is a comment that Dr. Singh mentioned in the pregnancy seminar. It's talking about preconception conversation, and I think that's just as important here with a transplant candidate, with the transplant candidate's family, and for them to be as educated as possible in what's going to happen, what the steps are. First off, it's not 40 years ago. Transplant is not perfection, but it is better than it was 30, 40 years ago. More people are getting them. More centers are performing them successfully with better long-term outcomes. I also think it's really important that everybody has all the best and honest truth about day 1 to day 365 to year 20, so that they can take that and make other people understand. Because again, like Annie said, and we've been talking about all day, when heightening the anxiety around any procedure, especially something as big as transplants, that is not going to put the patient in the best, both emotional and even physical space to be ready for any procedure, especially a transplant.
I think we got talked about a little bit, but I think we took one step forward and maybe 2 or 3 steps backwards with our listing requirements. We're able to list a congenital heart disease patient a lot easier, but in order to move them up on that list became very difficult. So we're able to get them to a level 4, but in order to get them to a 3 or a 2 or a 1 is very difficult now, because of those treatment options that we saw aren't necessarily viable for them. So as an advocate, I think that's the elephant in the room that needs to be talked about more. And how do we get those options available, or change the requirements so that those options are available to move the congenital heart disease patient up on the listing status, so they're not waiting, untold amount of time.
It's great feedback. So, and then we talked about Eisenmenger syndrome in pregnancy. And, in the interest of time, I think we'll just sort of address both of those at the same time. So, Annie, you're making gestures. You have some opinions on that?
No, I don't know. I tried getting onto this virtual program, and I've remained in the waiting room. I'm still in the waiting room to try to get in. So that was one of the sections, unfortunately, I did not get to see.
I'm so sorry.
Yes, no, that's okay. So if you're looking for them together, I unfortunately don't have much to say to that. So why don't we go on to our other guests?
Okay, all right. Eliza and Joe.
So when I was lucky enough to transition to adult congenital care at a very appropriate time before I was, before I got married and before I was planning whether I wanted to have a family or not. And about I don't know, maybe I was mid-30s or so. And my husband and I had specifically decided that we did not want to have a family. And my doctor said to me, you know, let's be very open and honest. Do you want to have a child? Are you interested in carrying, you know, a baby? And I said no. And he said to me, is it because you have a CHD? Because, you know, we can get you into the right care. We can work through this. We can support you through this. And he, you know, and he said, and it's possible for you. And I really appreciated the honesty in him broaching a subject that could have been very hard for a caregiver to a woman in her mid-30s. And two, for letting me know, honestly, what options I had, that, you know, it wasn't going to be as quick and easy as, say, my sister who had 2 kids very easily, or anybody else, but that he would be there for me. And I think the conversation today about pregnancy and CHD is so important because, one, we know there's not enough care across the country. So when you have programs like this, it gives people a little bit more hope, 1, to do their own research, and 2, to ask the questions of their own providers. And, you know, again, I'll just say, start early. I think one of the doctors mentioned talking about birth control at 13. That's amazing. Everybody should have a conversation about birth control at 13, but especially a CHD patient. So.
That's great. Joe?
Yeah, I think on the pregnancy topic, they talk a lot about, you know, education and what these kids or these CHD girls were told when they were, you know, young, and having to re-educate them. And I think that goes to the bigger picture of a lot of what these kids were told in general as when they were young isn't necessarily true anymore. And so we have to go back as clinicians and as advocates and re-educate them, retrain them. What is correct now? You know, the information is changing, this field is evolving as we sit here. And so each year that this symposium is held, you know, there's new information coming out and we're learning new things. And so, you know, we have to continually evolve. And so what we were telling them 10 years ago is maybe not true anymore. And so that goes to pregnancy, and it goes to a lot wider things, you know, as far as their care as well. So we have to, I think Dr. Lin, you used the term, you know, reverse transition. We have to re-educate them about what is available and what is out there.
Thanks for that. So in our last sort of minute and a half, I just wanted to open up the floor and see if you guys have any other thoughts about where we should take the symposium, as well as our other educational activities, and then of course also invite all of you to join our educational advisory board as well. Any thoughts, Annie?
Well, I think this is wonderful, and I love that you had this entire day specifically for those with congenital heart disease, the patients, and so that not only the patients could see it, but the family members as well, because by having both of them work together, if the patient isn't able to ask the question and they have their family member with them or on the phone with them during an appointment, they can sort of help them as they're shutting down to ask the question that maybe they were preparing for but forgot. Mm-hmm. You know, I think continuing on what's been happening and what will continue to happen as we age, and learning about the different things and having more updated information with what's current and, you know, the outcomes and the research is just wonderful. And being able to do this with the doctors and also doing it with more than just one language. I mean, that was pretty amazing that we now have multiple languages, because, you know, people come from all over the world to come to our world-renowned facilities here in the United States, and being able to have those interpreters and people to help them and show them that there is a program like this that they can tune into, if not on the day, then later on, so that they can understand and get the help and then also ask the questions. So, I mean, honestly, you've done a fantastic job. You and your team really have, and I think it's wonderful that you've opened it up to so many people to come in and not only listen but speak too. So thank you for that. And yeah, I think if anything else, it's just continuing on how patients are managing with their own care and working with the doctors and what they've seen on their end.
Wonderful. Thank you, Annie. Eliza?
I've always felt unique and special because of my CHD. It's been, something I may not have always shown outwardly, but I've always inwardly been very proud of what makes me so different from everybody else. But then participating in something like this and spending the day listening to our what's next and where the future is empowering. And it's empowering me as an adult to continue to take care of my CHD. I think that this is what is going to empower our teenagers to stay in care and to successfully transition, knowing that they're going to learn how to advocate for themselves, and they're going to learn how to speak their truest voice. I think these conversations are so important because I do want to point out that these really are conversations. These aren't just a set of rules. Don't go skiing, don't go, parasailing. This is a very different way of communicating your health, your holistic health, than it was as when you're a kid and when your parents are in charge of that. And I think we take this empowerment, we continue to use it within our CHD communities and with our medical provider, but then we take it a step further and we use it for our entire care. For everything as we get older and as we mature, we take the same approach. And I think that way we can be healthy, rounded people in all ways.
That's wonderful. Thank you. Joe?
Yeah, this is always one of my favorite weekends of the year at this conference. I think that the group of people that you put together is just, it's empowering, and the information presented is realistic. It's not whitewashed, but to see the group of people that are working for us, the patients, to help us live longer lives, better lives, is really motivating, and it invigorates me as a patient advocate, to want to go out there and do more, because I know that there's a group of amazing people working there for me and for us as patients. So it's just it's a great event, and I'm already excited for next year.
As am I. Thank you guys so much for joining us today. It's been absolutely fantastic having you, and it's been fantastic getting a chance to wrap up the session this way with your final thoughts. Thank you, Annie, for joining us in the studio, both today as well as earlier this week. Thank you, Eliza, and thank you, Joe. So for all of you who are joining us from online, it doesn't stop here. Okay, each of us is on social media. Please continue the conversation. We also have additional content online from earlier this week when we had the Adult Congenital Heart Awareness Week, and you can check out all that on the CV DeBakey Education station on YouTube. So join us for those, and then send us your questions as they come along. We will continue having a conversation about all the good things you can do to make a better diet to be compliant with your heart failure diet. I also want to make sure that I thank our supporters. So I want to thank all of our vendors and sponsors that made this possible, because it really wouldn't have been possible without them. If you haven't had a chance to do so yet, go ahead and check out the virtual exhibits where you can actually learn about a lot of the medications and devices that we use to take care of our adult congenital heart patients and optimize their quality of life every day. And then, of course, I'd be remiss if I did not thank the DeBakey Cardiovascular Education team, because, as always, they worked day and night to make this entire week and today's symposium an absolute success, as well as, of course, the video production team, who are incredible professionals and make this as slick and beautiful as it can possibly be. And then finally, I want to thank all of you patients and all of you family members who have been such huge supporters of not only our education content, but also the Patient-Centered Outcomes Research Stakeholder Group. And I want to give a shout out to all of our friends in the adult congenital heart world, such as Dr. Fred Wu, Dr. Alyssa Bradley, Dr. Carrie Schaefer, Dr. Sabrina Phillips, who is one of our founding members of the Houston Methodist Adult Congenital Heart Symposium so many years ago when we first started. You have all been wonderful. Dr. Ryan Jones, who we miss you very much. Thank you all for being both here in person, online, as well as in spirit, and making this successful event 7 years in a row. We look forward to seeing you all next year, but of course we also look forward to hearing from you online and in the future. Thanks, and have a great day.